Welcome to the Dr. Lexi Show, where I take pregnancy topics and break them down as best I can to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today, I am joined by Marybeth Tomory. Did I say it right?
Yes,
Tomory?
you did. Yes,
it's
did.
like amore.
Like amore.
That's what I hear.
Mm-hmm.
And I'm just going to call you Marybeth because we don't need last names here.
Nope.
Marybeth, tell everyone, please, what you do and why you're here.
I am a high-risk OB sonographer. So I work with perinatologists and patients that need more extensive care, more on the ultrasound side.
Yeah.
We give really good, high-quality, high-detailed exams for patients who are at an increased risk of chromosomal abnormalities or heart defects or have a family history. Also, people that have multiples in their pregnancy. So twin, triplets, quads, like high-risk multiples, we handle their care.
Okay. So can you tell us how you got to where you are? Like, what kind of training did you have to do to now do what you're doing?
Yes. Well, I think people generally, the general public, don't realize how much education sonographers do have.
Right.
We are kind of seen as ultrasound is only for babies, you know, and very flu, you know, like it's all fun and fluffy. And I think the majority of us, especially those of us who work in high risk, realize that it is definitely not all sunshine and rainbows.
Yeah.
And we always hope for that.
Yeah.
But we don't always get that. So we, as sonographers, I think we are definitely thrown into this world of needing to be very highly skilled and to understand normal and abnormal anatomy and how to see that. And I think people don't realize that ultrasound in itself is highly user dependent. I like to think of like when you're doing an ultrasound, you're like looking through like at a cave. You're like looking in a cave with a flashlight.
Okay.
And the flashlight, you only see what that flashlight is looking at.
So if you don't point it in that direction,
you don't see it, you're not going to see it. Now, CT, MRI, is like we are throwing on the fluorescent lights and you can see everything.
That's a great analogy.
Right?
I like that. I love that.
And I also feel like the heavier the patient is, the dimmer our flashlight is. So it can be a little trickier.
Yeah.
So as a sonographer, you know, we are really trained very well to look at different type of organs and their disease processes, things of that nature. So
if someone is out there listening and they're like, I want to be an ultrasonographer, what kind of training would they have to go through to kind of, because I guess you can be an ultrasonographer and then you can be a specialized ultrasonographer?
Yes and no. So our schooling is there are certificate programs, there are associate degree programs, there are bachelor degree programs. So we do kind of run the gamut of the type of education that we have. The most common, I think, is an associate's degree, is a 2-year program. That is on top of the prerequisites that you already have to get into that program. So you're kind of going to college for 3 to 4 years and you'll just end up with an associate's. Not that that's bad, but you know, there is variations in the type of level of degree that you have, but there are certain types of schools. So you can go to school to be a general sonographer. Like most programs that contain OBGYN in and of itself is based in a general program. So you'll learn general, which means like abdomen. So like liver, kidneys, gallbladder, pancreas.
That's for an adult, right?
Adult,
Not a fetus. We're not even talking fetus yet.
We're talking fetus. We're talking
people.
Abdominal.
Yeah.
And then that's also small parts. So we also do like thyroids and testicles. We do that as well. So an OB.
They call those small parts? That's what it's called?
Small parts. Yes.
Stop.
And we have a small part probe as well.
That's adorable.
I know, isn't it?
Small parts probe.
I don't think many men appreciate the small parts. I mean,
term.
It just means superficial.
Yeah. So is the probe for the thyroid the same as for the testicles?
It is.
The small parts probe.
Yes, small parts probe. But the same vaginal probe for transvaginal imaging is also can be used in prostate imaging
for
as
rectal.
well.
Okay.
Yes.
Okay. So we have general ultrasound stuff, then we have the abdomen focus, then we have small parts focus.
Yeah. So a lot of general programs are general, small parts. That kind of covers your general program. And then you have OBGYN. And then
is that a whole separate thing, or everyone gets the base training?
No, it's a separate thing.
Okay.
But typically most general programs contain an OBGYN portion. And again, this is just, you are scratching the surface. And I think generally a lot of people, the general public, if you're interested in sonography, OB is really what we're known for. So a lot of people do go in to ultrasound thinking, I want to scan babies. Like that is just, again, the flu part of it. And don't get me wrong, it's my favorite part. It really is my favorite part. So I don't want to downplay how much I actually do really like that part.
Yeah.
But a lot of people get into ultrasound thinking that OBGYN is just where it is. So most people that go into ultrasound go into some kind of a general program, and OBGYN is part of that. There is a separate vascular program. So sometimes those are done concurrent, general OBGYN, vascular. Cardiology, like if you want to be an echocardiographer, is typically an entirely different program.
So many layers. We share the same physics component. Okay. Ultrasound physics is the same component, whether you're in general, OBGYN, vascular, that is, physics is it. And physics tends to be a little bit of a weeder class for us because it is so hard. And you have to become a registered diagnostic medical sonographer in the United States. There's some initials that come after your name.
It's ARDMS is the American Registry of Diagnostic Medical Sonographers. So in order to become an RDMS registered sonographer, you have to pass a physics test, dedicated physics test, and then a specialty to become a registered sonographer. So whether that is a physics test and then you pass your general boards, like your abdomen, or it's called the SPI, sonography principles and instrumentation is actually the name of it.
Okay. This is the
physics test.
A timed test. You go into a testing center and take the test.
Yes.
Kind of thing.
Yeah.
Okay.
I took it 20 years ago and I passed by 1 point. I still passed.
And no one would ever know that.
No.
Thank you for sharing, because tests are hard.
Here's the thing. Yeah. I'm not a great test taker, and
Same.
I excel in anatomy.
Yeah.
I excel in that part. I don't excel in physics. So that's always been something that it's really hard for me to learn.
Yeah.
And it's hard for me, to not, to understand things that aren't like physical, like quantifiable in that way.
Yeah.
Like a pulse is a pulse, and continuous pulse wave Doppler, like all the theories have always been hard for me.
Because physics is I always remember it from college. Like, if I throw a ball at this angle, will the trajectory take it X far? And how fast is the velocity at the peak of the curve?
Yes.
It's just too much like hypothesizing or whatever.
And it just it doesn't click in my brain. So when I took my physics boards, I remember very vividly thinking, this is the best I'm going to get. Like this is not the part that I'm going to excel at as a sonographer. This is not my bag.
It's not your jam.
Not my thing. So, and I'm okay with that. Like I said, I passed by one question.
And it's passing.
Literally, I was like, a win is a win.
That's right. I'll take it.
I will take it. So,
I'll take it.
But I knew that is just not, that is not something that's going to fuel me, or that I will then traject my career as this part. Because I'm very good at the anatomy portion, and that blew out of the water of all my boards. Because that was what I felt the most comfortable with and what I understood. And it's okay.
If someone fails that exam, they just take it again?
Yep. They can retake it. You can honestly take it as many times as you want.
Okay.
You really can. I think there might be a limit. If after 5, you might have to go back and retake a physics class.
And then do it again.
Yeah. And that has changed since I went to school. So
Got it.
There has been. And there was an old physics test that I actually took. This is the newer physics test. I never took this test. So this particular test I did not take. But anyways, So physics of ultrasound just in and of itself is very difficult, and as it should be.
Yeah.
You really should understand how the machine works, why it works, why we are able to use it in a pregnancy.
Because you're running the machine.
You
it's like your machine.
doing the machine. And, you know, there are things that, yes, to understand the machine is not actually how you're using the machine. Like real life versus, you know, learning physics is different, right? Like the practicality of what you're doing in front of your machine every day. No, you don't need to understand, you know, your velocity principle. That's not what it is, but it really does help you to get better images if you understand the tool that you are given and why it works for you and how it works for you. So there is an understanding of it. And I'm sure as a reading physician, you know, when people know their machines, you know, when you're looking at a heart, someone who really understands how to adjust the settings, how to adjust the velocity, being very intentional. It gives a better exam for you as a physician to read and for the patient. Like
absolutely.
It's very intentional scanning, but it's also understanding how to use the tools that are given to you.
Absolutely.
So there is, we say like physics is a big thing, but it also is so helpful if you can understand how to utilize it in your daily life.
And as she said, like a reading physician. So some people might not know too, as a maternal fetal medicine specialist, it's kind of like if you think of, my friends in real estate. Well, they might do commercial real estate. They might do apartment. I don't even know what you call it.
Yeah.
What's it called when it's like homes? It's not commercial real estate. It's residential real estate. Right? So they might do renting.
Look at us go.
We know so much about real estate. But it might be, you know, big buildings, businesses, rental properties, buying of homes, leasing, selling, all this kind of stuff. So every little field is a little bit different. So as a maternal fetal medicine specialist, you have the terms maternal, fetal, and then medicine, right? Some of us do a lot of delivering and operating still. Some of us do a lot of clinics. Some of us do a lot of ultrasound.
Yep.
And the ultrasound for us is the interpretation. And I'll tell you, since I've trained in OBGYN and maternal fetal medicine, I took physics in college. And I think that's a requirement to get into medical school, right? Yeah. But once you're in medical school, you don't take another physics class. Once you're in residency training to be an OBGYN and then the subspecialty for maternal fetal medicine, I've never seen a physics book again.
Yeah. Which is great, honestly.
Which is great for me. But the reason I bring that up too is like when you have an excellent ultrasonographer, you learn from them.
Yeah.
Because I'm like, man, that picture is a little hazy. Wonder what we could do. And then someone like Marybeth comes in and is like, oh, I'm going to take the gain. I'm going to turn it up or down. The frequency is going to do this. And I'm going to take the velocity and then the millihertz or I'm like, oh my God. And like, I'll look at a book. I'm like, they never taught me that.
Yeah.
You know?
It is hard.
It is hard.
But it's also like an art.
It is like an art.
I'm kind of like, watch this.
Yeah.
It's one of my favorite parlor tricks ever.
100%.
But it's understanding that, you know, and understanding, you have to understand the big concepts in order to pass the test, but it's really about how to make your job easier.
Yeah.
And again, our machines, like they've gotten so good, like amazingly good, that if you don't learn that part, you're a machine.
It's your base, right?
This is we have a word. We call it knobology, right? Like knobology is understanding.
People, get your minds out of the gutter if you heard knobology. Please elaborate.
It's really understanding your machine and understanding the setup that you have. It's like if you're driving a car, you don't necessarily need to look where your volume button is. You automatically know, if I'm going to turn it up, I'm turning up on my steering wheel.
But you know in your car.
Yes, because you are familiar with the tools that are at your disposal. And, a long-term sonographer who understands his or her machine is going to be able to do that as easily.
Yeah.
And it really just makes our lives easier. It makes your lives easier. But that takes time.
Yeah.
But it also takes effort on the part of the sonographer to do that.
Sure.
So,
for sure.
Yes, we have basic presets, things like that. But I mean, there really is an understanding of
yes,
it. So
absolutely.
I know we took a small little tangent, but going back to how to become a sonographer.
Yes.
So when you pass, hopefully, your SPI or your physics credential, then you take a specialty exam. So the specialties exams, there's many of them, but there's a special abdomen, which includes the small parts. There's an OBGYN, there's echocardiography, there's vascular. So all of that. And then there are subspecialties within, like pediatric sonography is one of them. Neurosonography now falls under the pediatric sonography credential. So if you are Googling as someone who's interested in sonography, it will tell you that the highest paid sonographer job is actually a neurosonography, which is no longer its own credential. It's under the pediatric credential. So it still says, I know you're shocked that Google is wrong by this. It still says it's the highest paid sonography position. And it probably is one of the highest paid, depending on your location and your years of experience, things like that. But it now falls under pediatric sonography.
So why would pediatric sonography be
Neonatal
the umbrella
heads.
And then neonatal
just
heads?
Neonatal heads. Yeah, that's what they're calling neurosonography. It's like a neonatal.
Okay.
So, through the fontanelles.
Because if you're an adult walking around, no one's going to ultrasound your head. They're going to MRI or CT it.
Right, but
is that the thought?
We do some transcranial Dopplers.
You said doo-doo.
We do.
Yes, I got her to say doo-doo.
We do them.
We do do that.
Ultrasound does perform transcranial Dopplers.
Yeah. It's like a vessel.
That is not my area of I have no clue why they do that. I don't
Interesting.
know. So that is a thing.
Okay.
I have seen it. I can appreciate that is done. No clue how to do that.
Okay.
Yeah.
Good to know. All right.
Now, fetal heart, that is also a subspecialty exam. So
I
think
layers.
It is very layered. And you really can't go to school just to do fetal echo. You can go to school to do echocardiography, but you're starting as an adult. You're starting on normal adult hearts. And so you can go to the way I did it was general OBGYN sonography, MFM sonography, fetal echo.
Okay. So you don't have to do adult echocardiogram.
You can.
But you don't have to.
You can go the other way and go adult echo, pediatric echo, fetal echo. There's a little crossover there. There's definitely a crossover. And, I can see both areas being really great. Honestly, I am so impressed by the sonographers that do pediatric echo, especially on these really complex cardiac defects. And after they've had, surgery to fix the defect, that to me is mind blowing. It is mind blowing to me that they can do that. Yeah. And I look at it on the fetal side, which is, where we live. And, I love how I can find a heart defect and I can label it and I can dissect it, but I like my patients in utero. I don't like them out of the body. Yeah. I can appreciate them just in utero, right where I like them. Yeah. But I really appreciate the echocardiographers that do fetal, that do pediatric, and then follow them through adulthood. That in itself is pretty amazing. Yeah. So
that's crazy.
But if you think about it, there are so many subsets of ultrasound. There's all these tiny little worlds to live in. And when I got started, I did not want to do OB. I was like, it's awful. That's the worst thing ever. And again, I was in school with many people that were like,
that's what I want to do.
Baby ultrasounds. And I was like, give me a carotid Doppler any day. I think part of it was it seemed too fluffy for me. I'm kind
of what you heard about it.
Right.
Didn't fit what you wanted to do initially.
Right. Yeah. And so I think, I went in thinking I love ultrasound. I walked into an ultrasound room when I was 16 and, I just recently ran into the woman who was doing that ultrasound just within the last 6 months. But I walked into a room when I was 16. There was an abdomen being done and I was touring the hospital for another reason. And I literally walked in and I said, that's what I'm going to do. And I've never changed my mind. 16 years old, I knew from the get-go what I was going to do. So
I was 14 when I knew. I feel like we have the same kind or a similar kind of you just had this feeling, right?
I was like, I don't see myself doing anything but this. Like, this is it. So yeah,
I love that.
Okay. That's very cool. So I chose to get a bachelor's degree, which at the time I was in one of the only bachelor degree programs in the United States that I know of. It was in 1997.
So when you say bachelor's degree, do you mean your undergraduate bachelor's degree? Which do you have to have that to go on to become an ultrasonographer and go to school for ultrasonography?
No, you don't.
Okay.
Now, there are prerequisites, like your basic English and your math, like those things.
Yeah.
And a lot of programs, they do require you to have a really high GPA. There's only so many spots. Like, you have to really work hard to get one of those spots.
Yeah.
So there are certification programs, there are associate programs, there are bachelor degree programs. So there's just kind of a range of degrees, but it really depends on your registry and if you can pass those registries and be a registered sonographer. That's the goal. So all that schooling does make it through your clinics and your didactic portion. It makes it so that you can sit for your boards, that you qualify to sit for your board.
So you don't have to go to undergrad to do it. You have to take some prerequisites along the way.
But there are specialty programs. So you want to look for a school. Not all colleges have them, but they're very popular in community colleges, which is great. I do think, they've been talking for many years to make this a bachelor's degree program. I can see where there's a lot of benefit to that. Yeah. For sure. But not all schools have it. There's definitely, you want to look in your area for diagnostic medical sonography programs. That's pretty much what you would search for. Also, you have to decide, do you want to get an associate's? Do you want to get a bachelor's degree? Things like that. Will you get paid more having an associate's or a bachelor's degree? Typically not in this field. It's really it's really being a registered sonographer, your experience. That's what's going to pay you more. Now, sonography has a very high rate of injury. So new statistics say that 91% of sonographers scan in some kind of pain.
91%?
91%. So you really have to think about, and up to, I believe it was 15% have a career-ending injury. Wow. So you have to kind of think of, if you have an associate's in this program, what can you do with that afterwards? Yeah. If you have a bachelor's, what can you do with that afterwards? Some people move into applications, like teaching people how to use the machine.
You guys are like athletes, because you have to think your career could be short. What are you going to do after?
What do you do, right? And then you have to also think would you want to move into management? Sure. Would you want to move into, applications? Do you want to travel? Do you want to do, there's other things, but we are a little limited in our degree in and of itself. Yeah. So, I've always thought, higher education will never not serve you well. I'm a big believer in, if you have the time and the money and you can do it as early as you can, as quick as you can. You'll never regret that decision of having that. Will you see the effects of it right away in your career? Probably not. Yeah. Probably not. We're talking long-term goals.
Yeah, for sure.
Long-term. So there are different degrees. There's different degree paths. But ultimately, the job itself will not pay you more, but it might serve you well in the long run.
I like it. So, okay. So now, since Marybeth has been great enough to share with us what she does, I would like to jump into some questions. And Marybeth has no idea what these questions are. I didn't even tell her I was going to do this. Marybeth.
Okay.
There are questions that every guest gets. They're all the same.
Okay.
And most of them are surrounding pregnancy. Okay. So we're going to do 10 questions, and then we have 10 true or false. So if we go off on tangents, totally fine. But I just want to kind of see what you know.
Okay.
And Marybeth, do you mind, how many kids do you have?
I have 2 children.
2 children. Yes. So she has been through pregnancy before. So I feel like sometimes people might know more of the answers if they've had a pregnancy before.
That is true. Right? And I had preeclampsia when I was pregnant. So I was so lucky to have high-risk pregnancies. And
oh my gosh.
That is why I'm a high-risk sonographer now.
There we go. Did you have preeclampsia in both your pregnancies?
Yes. Yeah, my mother did. My sister did. I had both of them. Yes. So, it was well managed, but it definitely leveled me up. But really, it was the trajectory to get me into this.
Yeah. Well, and I did not know this. And I've known Marybeth for a while too. I did not know that. And it brings me into the point of, if you are pregnant, thinking of becoming pregnant, I would advise you to go to various websites. One that I know of off the top of my head is the Preeclampsia Foundation, which is preeclampsia.org. And you can do your own kind of calculator risk stratification to see if you are a candidate to do what we call now by taking a baby aspirin once a day to try to decrease your risk of getting preeclampsia.
Yeah.
Some of those things are kind of like she mentioned, a mom who had preeclampsia, a sister, so basically a first degree relative.
Yep.
If you had it in a prior pregnancy, you automatically fit that criteria.
Yes.
And I have a download that you can go to as well if you want something quick and easy. And I'll include that information below so that you can go to that. But whether you go through my website or through Preeclampsia Foundation or anything, just educate yourself about it.
Absolutely.
The videos that Preeclampsia Foundation has online too are fantastic. I mean,
I've seen some of them. They're great.
They're
great.
awesome.
Yeah.
And plus you can see stories of other people who had preeclampsia.
Yeah.
Because there's various degrees. It can be like, oh, I had preeclampsia, they delivered me early, and then life was great.
Yeah.
Or you can get preeclampsia and it can lead to so many other things like seizures and strokes, and it can affect you lifelong actually for your heart function. It's just, it's a crazy disease. So if anything, if I know of something rather that could decrease the risk of someone getting that, I'm going to push for it and make sure everyone that I see gets educated about it.
Right. And we do, we're learning so much more about this, and we're being, I think, so much more proactive than reactive. I feel like that's the new kind of what we're pushing that so much more. And even I in healthcare, even because I wasn't particular into MFM or OBGYN, I missed a lot of the signs. So looking back, I'm like, oh my gosh, preeclampsia, but
sometimes they're mild too.
I have 2 healthy kids.
There you go.
I'm so grateful for that. It was caught in time, and that's fine. But you know, I feel like I would have been much more aware of it if I just knew more of the signs. And I think too, coming from a background where my family is non-medical.
Yep.
They didn't realize they had preeclampsia. Does that make sense?
It does.
Like, you're like, oh, well, blah, blah.
Like my mom said she delivered early. She's not sure why.
Yes.
Or my mom said she may have had a blood pressure thing, but she's not sure.
Yeah. Yes. Or I was on bed rest for a really long time.
That used to be a thing back in the day.
It used to be a thing. I could barely move.
Our moms, right? Our generation.
Yes. Our mothers.
Our mothers.
So you do have to, like, once it starts clicking, it's easy to see, but I think having non-medical people explain their medical issues, and obviously them not understanding it, it's almost like, deciphering another language.
It is.
Right. And then once you start putting it together. So I was like, oh, I had to tell my daughter she's going to have to.
and that's,
my own daughter is going to have probably very high risk pregnancies now.
Exactly.
But you know what? We know now, and that's okay.
We do. And you make 2 great points I want to bring up. Number one, telling your children about your personal obstetrical history, particularly your daughter's, so important. And we honestly just forget, because by the time she's probably grown and having children, you might be like, oh, wait, I forgot. Hey, by the way, I got to tell you this.
Yeah. Well, I think I won't forget, but my mother definitely did.
Yeah.
And then my sister definitely did. Like,
they may not have, and
they
how
didn't
much
put it together.
Or how much, and this is the question too, how much do you think that they just weren't told the term? Because I think that's a thing too,
I think
right?
It totally could. And my sister's heavier than I am, and she was a smoker at the time. So
other risk factors,
right? So like, what was your genetic history versus maybe being at a higher BMI or being a smoker, like, so things like that. I just don't think it was all put together. Yeah. And now we've determined it is very genetic. Like my personal history is very genetic for preeclampsia. So.
And the other thing you bring up, it is. And preeclampsia is one of the things that anytime someone brings it up, I feel like I can't stop talking. The speed of the rate of my speaking increases. My tone gets louder, and I get jazzed about it because I'm just like, ooh, this might be a time to educate someone else.
I'm passionate about it. Yeah.
And so part of what I'm doing is kind of, and I had no idea, again, that she had preeclampsia, and we weren't even getting into this today, but people kind of might be thinking, okay, if you as Dr. Lexi, if you're offering these consultations online, right? If you're able to see me without insurance, without a referral, cash pay, and again, these are for people in states in which I'm licensed, which you can check that out on the website too. It's like, well, why would I need something like that if I'm seeing my OB? Well, if you're seeing your OB and no one's ever brought up the term preeclampsia, this is a great example because that's what we would talk about too. Like, hey, let's go through, have you looked at a checklist to see if you're at risk for preeclampsia? Hey, have you looked at these things to see if you need to be screened for obstructive sleep apnea? Some of the basic things that your OB may not have gone through with you, or may have
kind of glossed over.
May have glossed over.
So much. There is so much in your, especially in your early OB visits, in your first OB, there is so much information that you need to tell your doctor. Your doctor needs to tell to you. And I don't think most OBs now, they don't want to be your only source of information.
No.
So it takes you as a patient, like, do I know the obstetrical history of my siblings, especially your sisters, right? And then of your mother and your grandmother. Like, sometimes you don't know to ask those things.
Exactly.
And then if they've already checked that box, nope, you don't have high blood pressure.
Exactly.
It kind of gets glossed over.
Exactly.
And it's not through anyone's fault.
No.
It just is, again, there's so much to get done and to know in a first visit. You literally just can't get through all of it. You just can't.
Yeah. So even if you ever want to do that consult there for an hour, you can go online, you can book them. It's super easy. There's sometimes nights and weekends open. It's hopefully flexible for people's schedule, which I like. And if you don't want to talk to me and visit about this and you just want a little bit more information, one of the things Marybeth brought up, the questions, right? You got to know what kind of questions to ask. And it's really hard to get that information just from random searches on the internet. I still call it the interwebs because the World Wide Web, right? The WWW.
Oh my goodness.
When it started. The fact that we saw the internet be invented and like lived from, that still fascinates me.
Yeah.
But there's a download that you can look at. It's 13 common questions to ask your OB provider. It's at drlexihill.com/advocate. That's a great place for you to start if you're just like, hey, where would I even go at my first visit? And it kind of goes like first visit, follow-up visit, near the third trimester, before delivery. Some of those big, I think they're basic questions, but they're important questions.
Very
important questions.
I thought it was a great handout.
Thank you.
I loved
Thank
it.
you.
Mm-hmm.
And speaking of questions, we're going to do it. All right.
A rocket fire.
Question number 1. What does the abbreviation OBGYN stand for?
Obstetrics and gynecology.
Love it.
I hope I know that.
Yeah, I hope you know that too. If not, we are in big trouble.
All right. Ask me what MFM means.
That's question number 2. True. And again, swear she has not seen these questions. Nope. Question number 2. What do the letters MFM mean?
Maternal fetal medicine.
That's
my jam,
medicine.
baby. Oh,
that's right.
It's my jam.
Do you have patients, since you've been working with maternal fetal medicine specialists for so long, do you ever have patients or have you ever had patients come in and they're like, what is this?
All the time.
And
literally all the time.
And they're there in the office. They've already been referred and they didn't understand who they were being referred to.
That is correct.
See, I think that's part of, there's so many holes in healthcare. I'm a healthcare provider. She's a healthcare provider. We know there are holes. I think it's one of two things. Sometimes a little bit of both. Number 1, did the referring person describe to the patient who they are seeing and being referred to and why?
Correct.
Or thing number 2 possibly, did the patient understand or did they ask questions or not ask questions to get clarification?
I think both of those things
maybe,
are true. Yeah, absolutely. Because a lot of times too, I think if an OBGYN feels that they're unsure, they don't want to commit anything to the patient, right? They don't want to unnecessarily cause worry and anxiety if it's nothing. So I think sometimes they tend to be a little more vague. And
I see.
Hey, let's just get this checked out. So they don't want to commit, but they also want to make sure the baby's okay. So I think sometimes patients come in with like, I'm not really sure why they sent me here because I've had ultrasounds at my OB's office. Or they seem to manage my medication just fine.
Right. So why am I here? Yeah.
But I always appreciate people working within their scope. And if you feel like that is out of your scope, this is why MFM is here. And
for sure.
You don't need to work. Like this is the whole point of us here. Like to me, I kind of feel like, why not use the tools at your disposal? Always. And even if it's like slightly above what you feel comfortable with, there's no reason to not at least advise your patients.
Phone a friend, right? Yeah, not a problem.
Totally. I'm a big fan of that.
I want people to understand what it is that Marybeth is tasked to do when she has been working as a high-risk OB ultrasonographer.
Yeah.
Because a couple of things. So first, when I see a patient, typically, this is a generalized statement. When I see a patient as an MFM specialist, the person who has seen them before me and had a lot of interactions with them is the ultrasonographer.
It's me.
Right. And so you have to think, and I learned this from my patients a lot too. When I introduce myself, they have already met a front office staff member, possibly a nurse as well, and like or a medical assistant, Jinx, and spent probably an hour with an ultrasonographer laying on a table with their belly exposed, which is a very vulnerable place to be.
OBGYN in itself is, I think, a vulnerable. You have to feel comfortable with your care team.
And had a conversation with an ultrasonographer. All the meanwhile, the ultrasonographer is not supposed to really do what the provider or the doctor's supposed to do, like tell them too much.
We don't diagnose in that way.
We don't diagnose.
Absolutely, which is my favorite part. I don't like to commit to stuff like that.
But your job is so challenging, I think, and so important because not only are you looking for any and everything that could be abnormal from the fetus to the amniotic fluid, to the placenta, to the cervix. I call the stuff inside the uterus the passenger. It's not just the fetus. It's the placenta and the amniotic fluid too, right? You're looking at all the passenger things. You're also looking at the pregnancy itself, meaning
maternal factors. There's
the
a lot up there.
Yes, the uterus, the cervix, the ovaries. We check the ovaries. You're doing all of these things. And then my first interaction with the patient, most of the time, a question comes from them like, they're scared, right? Like I'm seeing a quote unquote high risk doctor and I still don't know what's high risk about me.
Right. And I think if you have it, when you have been scanning for a long time, there is a confidence. And if and it just takes repetition. It takes experience. It takes time. It takes repetition. It also, to kind of help ease that patient's anxiety. There are ways that we as sonographers can mitigate that. And a lot of it is just talking, and calming. And, I always like to, like you said, people come in and they're not sure.
Right.
Almost 99% of the time when patients walk in, what is your understanding of today's appointment?
You say that to them, don't you?
Every time.
I love you for that. I do the same thing. And that's what we're supposed to do.
Right. It gauges me. Like it gives me a good gauge on how the patient is feeling. It tells me what their anxiety level is at, but it does tell me why do they think they're here?
What do they know?
What do they know? And so sometimes, if a patient is coming in for, say, a suspected heart defect, they think there's something wrong with the heart. Okay, I'm going to go take a look at that. I'll walk you through everything. This does not mean I am diagnosing. This means I'm looking at the head. I'm looking at the face. Here's the nose. Okay, give me a few minutes. Let's look at the heart, blah, 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 blah.
Like you can tell them what you're looking at without diagnosing.
Right. I can tell them.
But still communicating to them.
That communication is so important for patients. So important. And so I feel like I'm at the level, I'm very trusted by my physicians, especially as a sonographer, that if there is a heart defect, I can tell the patient, I agree that there's something wrong with the heart. Now let's go talk to Dr. Hill and we'll go through and she'll talk to you about it. That to the patient gives them a little bit of like, okay, that initial like, okay, now I know there's something wrong. Like you're not coming in and just giving them this, having an unrealistic or an expectation that everything is fine and then a blindsided. No one likes to be blindsided.
No. And I want to circle back to when you said you asked them an initial question, right? As to why they're there.
Yes.
I've got to go. Cause I, oh my gosh, now I'm getting all riled up again. Riled in a good way because it's, I want people to know too that when individuals in healthcare are trained, we're trained for the medical part. The amount of training and empathy and communication is very poor overall. Would you agree with that?
It's definitely not something we're taught.
No.
Right? Yeah. So we're kind of winging it. It really is. And it really takes repetition. And it's kind of sad to feel like I can only handle miscarriages because I've been talking about them for so long or with so many patients. But do I nail it every time? No, I don't nail it every time. But it really takes doing it multiple times to be able to read a patient, to be able to give her and her family the care that they need, especially in that moment. And it's tricky.
It is tricky. And for introducing though, just for like your day-to-day, like a day-to-day seeing patients, for me, I always make it part of a regimen, like a protocol. My name is Dr. Hill.
Yes.
Nice to meet you. Who's with you today?
Yeah, you guys do a great job of that. I don't. I'm like, I don't know who's with
Not
me.
Everyone does, though.
But I excel in other places.
But introduce the provider or even like the ultrasonographer, like I've had ultrasounds performed, mammograms performed, and I can tell when someone has been taught or at least learned how to communicate. They'll say, hi, my name is Jean. I'll be doing your mammogram today.
Yes.
Is that what you think you're here for? Do you have any questions before we get started?
It's almost like a teach back.
It is. It's, I circle back to Brene Brown. Clear is kind, unclear is unkind.
Every time.
It's clarity.
It is. It's really being very clear in your instructions, making sure we're all on the same page here. And that is where people, I think, really respond well.
I think so. And I learned a lot of those things. Some places I worked, they actually had little acronyms like, here's how you need to introduce yourself.
Okay.
And I was like, wow. I mean, I feel like I do that anyway, but thank you. Because I think some people really needed that feedback on you need to state your name, your role, and what you're going to be doing today. Yeah. And that should be standard of care. I do think in the last 10 years, companies have really tried to integrate that into their practices.
Yeah, I do too.
And the other thing, which I try to do, is come full circle. So when the appointment's over, okay, so today we talked about this. Yeah. Do you have any questions about this thing we talked about?
Right.
Or your plan? And the plan always includes the follow-up. Because if you just say, do you have any questions? You could get questions about, I got a bruise on my toe.
Oh, it could go run the gamut.
Right. So again, clarity and being clear in what am I asking about that you understand?
Yeah. Yeah.
And I talked with a provider the other day and they were like, I love it when they say, no, I don't have any questions. You explained all the questions that were on my list or everything I wanted. And it's like this I'm so filled with joy when that happens.
Yeah.
Right?
I love it. Our MFM scans, our level 2 detailed scans are crazy detailed. Like
crazy detailed.
And you know
Tell some of the things you look at real quick, like on a detailed scan. Some of the stuff that people might not know.
Sure. I mean, if you think about, I know we kind of got away from your rapid
That's okay.
fire.
We're going to get back to them.
Okay.
I will finish them.
Yeah. Here's you can use this analogy as well. So a basic OB scan will check if your baby has arms and legs. An MFM scan or a level 2 detailed scan.
Now, clarify real quick before you go further, just so the listener can hear. This is the scan done when?
Around 20 weeks, like your mid-pregnancy scan, like your full anatomy scan.
That everyone needs.
Everyone should absolutely have.
Needs this. This is a standard of care.
Have any scan in your pregnancy is this one.
Thank you. Okay.
If you are going to say, if you don't feel uncomfortable, if you don't want to have many ultrasounds, that's your right as a patient, this one do not skip.
Yes. And this is on the 13 questions to ask your provider.
This is it.
When and where am I getting my anatomy ultrasound?
Yes. And a lot of people do call it the gender one, because obviously that is typically the time that people find out, but it is so much more.
So much more.
Okay.
So start again with the basic versus the detailed.
So just if you can think about your basic ultrasound is going to have, like, we're going to check that your baby has arms and legs. Your detailed anatomy is also going to check the baby has arms and legs. But I'm also going to make sure the baby has all the correct bones in the arms and legs. I'm going to make sure the baby has hands and feet, that all the bones are in those hands and feet, and do they work properly? So if you look at arms and legs, everything else that I just listed, and now apply that to every other part of the baby's body. So your basic OB scan is supposed to catch all the basic big anomalies.
Big things.
All the big things. But your level 2, your anatomy, we just look at things in much more detailed, more because we're more educated in that we're highly trained. We are a good MFM sonographer is trained to think like a perinatologist. If you have a good perinatologist.
And remind people what a perinatologist is.
If you have a good maternal fetal medicine physician.
Just the same thing as a perinatologist. Just a different way to say it.
They want you to think like them.
Yeah.
And they will train you as such. So they want you to think like a physician thinks, and they want you to diagnose like a physician does. Yeah. So while we're scanning, it is one of those things that we're trained to think like them in the ultrasound room. So.
And it goes, I think, both ways too, like a perinatologist or maternal fetal medicine specialist or high risk OB doctor or high risk obstetrician. We're all those things, it's different names. I like to try to think like an ultrasonographer in a way too, because when I learned in fellowship how to read an ultrasound, I first had to learn how to do an ultrasound.
Yeah, absolutely. Yeah.
And in fact, I scanned more than I read in fellowship because we were just busy and that's how you did it. And so I was an ultrasonographer.
Right. And you only learn by doing.
Right.
You have to put your hand on the probe.
You do.
Will not be able to figure it out otherwise.
And having a good ultrasonographer is fantastic because they do think like the reading physician, which is great. And I know we're going off on a tangent with this, and this is the whole point of this, because now the question is, I have friends that are getting ultrasounds done for their, I'm air quoting now, detailed ultrasound or anatomy ultrasound. And first thing, number one, their provider hasn't explained to them whether they are getting an anatomy ultrasound, which Marybeth told us is kind of the basic big stuff, versus a detailed anatomy ultrasound,
correct,
which is for people who have a higher risk of having structural abnormalities with a fetus.
Correct.
Examples, tons. Advanced maternal age, pregestational diabetes. Those are some of the big ones, okay? So questions for your provider. Number one, am I getting a basic or a detailed 20-week anatomy ultrasound? Would you agree? Yeah?
I would agree. I also think for patients, they should know who is reading their
That's
exam.
my next question. And who's doing it. So I think both. So like
do you have a licensed and a registered sonographer
great question.
Registered an OBGYN? Like they have proven a minimal competency to be able to do that exam. That's really what passing a board is.
And the person who's doing your scan that day, like I would say when Marybeth introduces herself, she's not going to say all her accolades behind her name because that's just not how that goes. But if someone asked you, are you a registered ultrasonographer?
Oh, yeah.
Because they wouldn't know the big terms.
Proudly, yes. But I do get a lot of, your hands move very fast. Exactly how long have you been doing this? You know, and I'm like, since
Such
lunch.
a compliment. Such a compliment. And that goes back to the machine too. Because like I've scanned on different machines.
And you're like looking for buttons.
Yes.
And you're like
my first day on it, because I was covering a clinic in a different city to help out. And, you know, just so people know, and correct me if I'm wrong with this too, I'm right-handed.
Yeah.
I scan with my right hand. I'm clicking buttons with my left. I'm not left-handed, but I'm clicking buttons with my left hand. Does anyone do it on the other side?
Echocardiography generally does scan with their left.
Scan with left and type with right. So just
most people they learn to scan with their right, especially in general OBGYN.
Okay.
And they do the machine with the left.
With the left.
It almost makes you become very ambidextrous if you're not already.
It's different, right? So when
I always say, like, my right hand's the one that's really doing a lot of the work. The left hand is the dummy hand. It's just pushing the button.
Yeah,
exactly. It's like, fly it over. But my right hand is the very fine movements, the tension. This is the workhorse over
That's the
here.
workhorse. This is knobology, though, right? Come on.
This is just the busy one.
This is your knob hand.
Oh, yeah.
Right?
For sure.
Hey, don't disregard that hand.
No, they both work. They both
work.
play a role, and a very important role.
Now, in the mentioning of the machines, these machines, as Marybeth mentioned, they're so fantastic in their technology, but they are very different. The button placement is so different too.
Yeah, they're different on everything. Keyboards, non-keyboards, trackballs.
Even like what you see on the screen and where it's located is different, which is hard. And I have told patients when I have scanned them, if I'm new on a machine, I'll be like, you might see me taking a while with the buttons over here. I've been doing this for X amount of years. This is not my first ultrasound. This is a different machine. Yeah. And they see how slow you can be for the first go round. Yeah. And I know they're going, she doesn't know what she's doing.
She does not look capable at all.
But it's not that, you know.
Whenever I've I've been involved with demoing new machines at our office. Whenever a new machine comes in, I'm one of the first ones. I love that stuff. So that's really my bag. You know?
I love it.
But I always tell patients, I am new to the machine, not ultrasound. And those are two very different things.
Yes.
So right. So if you think about it, it's like when you're driving somebody else's car, you're like, I got to adjust the rearview mirror and I got to move the seat up. And you're like, okay, how do I turn on? It's the same analogy. It's just like that. So
it's like a rental car.
Yep. I always tell patients that, I am not new to ultrasound. I am new to this machine.
Okay. I want to go back to what you said too about who is reading the ultrasound. So yes, we talked about it's fine for you. And we would encourage you to ask who's doing your ultrasound, right?
Yeah.
Is it an ultrasonographer that's MFM trained? Or
most
not.
OBGYN sonographers are not MFM trained. Some are.
Good to know that.
But most OBGYN, and again, it really is important whenever you're doing anything in life, the repetition of it. Yep. So they are trained OBGYN sonographers to catch abnormalities, especially the big abnormalities. Right. And because that is their specialty and that is what they're doing, they should catch that on any type of early detailed scan.
Okay, so then here's my next question. If someone is getting an anatomy ultrasound, and it needs to be a detailed ultrasound. Okay. So a detailed anatomy ultrasound. So let's say that this
like
patient.
A 76811 is
like a 76811?
Sorry. Shop
I know.
talk.
We gotta like.
Let's use complete versus detailed. Let's
complete and detailed.
Yeah.
So complete is the basic that I said earlier.
76805.
76805. And the detailed is a 76811. And that's the more looking at all the like lenses of the eyeballs and the fingertips and everything, like the detailed portion.
Yeah.
I want y'all to know too that communication is so important. So if we were working together, we would speak in codes that are the codes that go to your insurance
language.
Company. Yeah.
It's a totally different language, but one we know well.
Yes. Because like I would be like, you want a 1-1 or an 05? Did you bill an 05? Can I bill a 1-1 today? Are they going to get a 1-6 coming up? And you're like, wait, what?
Yeah.
Like, and for doctors who don't.
I'll add a 19 in there. 76819 because, you know, maybe a little fetal growth restriction and then we'll put on a 76820.
Oh, yes. And wait, do you want a 2-1 or no? Because I don't want a 2-1.
I mean, is the baby anemic? Are we worried about that? I mean, we're doing CPR ratios. Again, do you see look at the rabbit hole we can fall so fast.
So fast.
Yes. And we both know exactly what we're talking about.
We do. It's like our brain is connected.
Again, she has taught me to think like her. Therefore.
Vice versa. I mean, it's just great. It's great. So the question I'm into now is this. So if a patient warrants a detailed anatomy ultrasound.
Yeah.
And let's say they're 40 years old, and that's why they're needing to get this. They should get one.
Yeah.
Say they're seeing an OBGYN.
Mm-hmm.
And the OBGYN has an ultrasonographer in their office. Does that ultrasonographer, let's say that they're OB trained.
Okay.
I don't know the answer to this. This is my question.
I'm like, I don't want to like throw anybody under the bus.
It's just a general question.
Yeah.
Are OB ultrasonographers? I just gave that scenario for a listener to be like, why? Yeah. Where would this happen? Right.
Yeah.
So if there's an OB ultrasonographer in your OB provider's office, whether you're seeing a nurse practitioner, midwife, OB, whatever, they have their own ultrasonographer there. Let's say that ultrasonographer is OB trained, like you talked about.
Mm-hmm.
Are they qualified from their training to do a detailed 76811, a detailed anatomy ultrasound, by definition that you understand from training?
Right.
I'm just curious. I don't actually know a technical answer to that.
Right. I think there are many ranges of what people are capable of. Like I do think the AIUM, the American Institute of Ultrasound and Medicine, has put out practice parameters. What should be included in a complete exam?
Right.
What should be included in a detailed exam?
And you guys can Google this and get it.
It is
not Google. Sorry, I mean I love Google, but I should say you can get on the World Wide Web.
AIUM practice
.org,
parameters.
I think, right?
You can see .org.com. I'd have to.
I'll put the link, but it's I believe it's AIUM.org.
But you can see very clearly what is included in each exam.
Yep.
Some of the things that we look for as high risk OB sonographers, they're kind of softer things. They're more subtler things. Do I think an OB sonographer has the training to do that? Maybe some of them do, but I think as a whole, no.
Yeah.
And I think that's just because they are not working in a high risk setting and they don't see as many chromosomal abnormalities like on a day-to-day thing. I think it's hard to get good experience in that.
Yeah.
So it's more just, yes, we need to know a lot of things to pass our registry. I think is very hard to expect a person who is seeing walkie-talkie OBs, young, low risk, generally probably 95% normal anatomies to be able to pick up the subtle nuances that sometimes chromosomal abnormal babies have.
Okay.
Now,
I agree with you.
Are we going to see, like with trisomy 21, are they going to see major heart defects like an ABSD? I sure hope so.
I hope so too.
Yes, I do hope so. But
would they know the nuances like you're saying? Like if that baby's heart is pointed upward.
But if the baby's heart is normal, the baby's heart is normal.
It doesn't mean there's not something wrong with it.
Right. But really the only thing we see is low set ears, a sandal toe gap, and a possibly slightly thickened nuchal. Are they going to catch that? Maybe not. And this is all about giving the patient as much information as we can to make decisions, whatever is good for their family and works for their lives. So it's a lot about that kind of stuff. So it's not that I don't think they are capable, but I think there are subtle things that in the MFM world and in the high risk OB world, we're just better trained to see. Yeah. it's not I don't think they're capable. I just don't think they have enough experience with it.
Right.
Unless they have worked under an MFM and they have that experience.
And they've received some type of extra training.
Totally.
So
that's really what it is.
When you go from being an OB ultrasonographer to an MFM ultrasonographer.
Right.
Was there another test involved in that?
There was not another test. There wasn't another test per se, but you do learn. So, doing your general OB studies, your general OBGYN ultrasounds, you should have a great foundation.
Yeah.
And to then build upon that foundation to do detailed ultrasounds, you're taking all this base knowledge that you know, and then you're adding to it. And it's like, it's like eating an elephant, one bite at a time.
So an OB office could have an ultrasonographer who
either had MFM training, or maybe they have an MFM that works in their practice.
I see.
That the MFM can say, hey, when you're doing your heart views, I really want you to put color on this certain part of the heart because I'm looking for this very particular thing, and this is why.
Got it.
And once you learn how to scan MFM, you can never scan any other way.
You can't go backwards and not look at all the parts.
No,
that just is not normal to your brain.
It does not happen. Now, it's kind of like when you learn carbs in food. You can't unknow the carb count of food. That's
oh my God, you have such great analogies.
I have a lot of analogies.
You can't forget the fat amount in that, or
fat is not bad. It's sugar that's bad.
No, I just mean like if you look at a thing of peanut butter, it's got
what it is.
Fat
so
in it or whatever.
Like once you are a trained MFM sonographer
to do all of it,
you can never not think that way. And especially when it comes to the fetal heart.
Yeah,
and it's so. I'm telling you, when I learned fetal heart, I was like, I don't get it. Like, does not compute. It was like,
when it's a moving target,
so much, and
moves so much.
And if you think about it, there's an entire registry based on this one organ. It's hard.
Yeah, it's hard.
It is hard,
definitely.
So 51% of congenital heart defects are not found before birth.
51%.
51, and
wow,
it's a moving target.
Inside a moving target.
It's inside a moving target, inside a moving target. And kids, they don't care what we're doing. They don't care. They're not like, let me sit here, apical, so you can see my heart. They don't care.
They show their bum and their back. And
I'm not here for that today.
And you can't see through bones. I always tell people this. Well, why can't you see the heart? Well, the baby is spine up and the spine is made of bones.
Right.
And I don't have a machine that can see through bones.
Right. Well, ultrasound and bones don't play well together.
No, they don't.
We don't. The physics.
The physics behind it.
What happens
there you go.
is those bones absorb or attenuate our ultrasound beam.
Big
so
words.
that just sucks it up. So that's why when you're early in pregnancy, we can see all those pieces of anatomy better. But if you are late and maybe getting your antenatal testing and we're looking for fetal breathing, you can see big rib shadows. That's because those bones have become calcified and they attenuate or they soak up our beam. So that's why you get those big rib shadows in there.
And I love that you said that because people assume the bigger a baby is, the more that we will be able to see.
Yes and no.
So
depends on what we're looking at.
Depends on what we're looking at.
Depends on what we're looking at.
So that
you get a little smushed in there.
Yeah. And so that 20-week ultrasound is still so important. Okay, so you have someone 20 weeks, they're getting an anatomy scan.
We've taken a lot of tangents, haven't we?
I know, this is my favorite one. Because for the 20-week scan, if they're getting it done at their OB office, the question I think that is still important to ask.
Yeah, what are the parts are included? And you can look them up as a patient on AIUM.
Who's doing my scan and who's reading my scan?
And who is reading it.
So is the ultrasonographer doing my scan? Have they ever been exposed to doing detail? Like, are they MFM trained at all?
Correct.
And who is reading my scan? Because I'll tell you this. If it is your OBGYN or an OB provider, air quotes here, that's reading your scan, when I trained in OBGYN, and anyone I know that's an OBGYN that trained anywhere in the U.S. that I'm aware of, their exposure to reading a fetal ultrasound
very minimal.
Was zero. We were trained in knowing if the baby's head down and maybe checking the fluid.
What we call POCUS, more point of care ultrasound.
Point of care.
It's
yes.
POCUS.
And then
which is great if you're in labor and delivery. And like, what is our position of the baby? How many are in there?
Yes.
Like it is actually really important tool to know, but it's not the small detailed stuff that we're trained to do.
Exactly. Exactly. And I just want to make sure if someone's listening and you feel like, or you know that you're a high enough risk pregnancy that it warrants getting a detailed anatomy ultrasound at that 20-week mark, ask your provider those two questions. who is doing my scan
Yeah.
and who is reading my scan.
Mm-hmm.
Because that is so important.
It really is.
I will give my opinion. You can give yours. If you need a detailed scan, you need an ultrasonographer who has been trained with maternal fetal medicine.
Correct.
And you need a maternal fetal medicine physician reading your scan.
Hands down. True.
Okay. I'm glad we agree on that.
Yeah, absolutely.
I mean,
we can dive into this if you want, but this is the part that I'm really passionate about, and the fact that patients don't know.
Yeah.
And they wouldn't know. They think, oh, everything is done at my OB's office. And I really don't. I personally know a lot of OBGYNs. I am friends with a lot of them.
Yeah.
And I'm very grateful for their education and other points.
Yeah.
But ultrasound is not their thing.
No, they're great at so many things too. It's just that's not their training.
So much. It's not. So it's an unrealistic expectation that unless they've had some advanced ultrasound training, that they are capable of reading your scans. So again, I'm a big within your scope of practice kind of person.
Yeah.
So the thing that bothers me, and we can take a tangent.
Do it.
I don't understand why insurance doesn't require that.
Yeah.
Why is an OBGYN who is billing a complete basic ultrasound getting the same insurance payouts as a perinatologist doing the same thing with a higher skilled sonographer with a maternal fetal medicine, someone trained in reading ultrasounds? Why are we receiving the same payments?
Mm-hmm.
And if you are going to provide that service for your patient, then you should also show that you are capable of reading that exam. So I don't think insurance, I think that we can again go off on a big tangent, but they shouldn't be getting paid the same. If you don't have a qualifying sonographer, if you don't have a qualifying physician, I don't think you should be able to do those types of exams. You want to do, I think, first trimester ones, you can totally do that. I think viabilities and dating, I think that's great. BPPs, gross later on in the pregnancy, that is where they do really well at. That's great. The anatomy scan, though, in and of itself is so important and so vital. Important. And again, 51% of heart defects we miss before baby's born.
Now, when you say we miss,
are missed just prenatally.
Period. Not missed. Saying, so if you were to, I'll ask a guesstimation.
Now that can be anywhere from a small VSD to tetralogy of flow.
Sure.
There's a whole gamut.
There's a range. But if you were to guess, and if you're like, I just can't guess the number, that's fine. If you were to guess, if they stratified that data, and I don't think this has been done, but you might, if you know, let me know. If they stratified that data and said, of scans done in red by an OB versus an MFM, do you think that percent would be different?
I can tell you this is the one data point that I know is that a detailed anatomy study done of the baby's heart and cleared by MFM has a less than 1% chance of having a congenital heart defect at birth.
That's a big difference.
A big difference.
So anyone listening, if you're getting a detailed anatomy ultrasound performed and that's what you need for your pregnancy, ask who's reading it, ask who's performing it, and advocate to have it performed somewhere where a maternal fetal medicine specialist is reading it. Because tell those statistics again.
Yeah, we do extended heart views, and those extended heart views do catch a lot of really small, especially cardiac abnormalities. Yeah. And I believe it's less than 1%, like at 1% or less than 1%.
Big difference regardless.
Big difference. But so, the chances, if you've had a good study, meaning your baby's been in a good position too. Sometimes we just have to try again.
It's the baby show. We're just kind of on the side.
We're just here.
Yeah.
But sometimes if we can't clear it, we never assume.
No, never
assume. So we'll continue to try again. But if you've had a good cardiac study with extended heart views, which is what the detailed exam performs, what that contains, your chance of having and your baby having a chance of a cardiac defect is minimal.
Yeah.
That is amazing to me. That statistic is absolutely crazy, mind-blowing to me.
And what Marybeth says too is don't always assuming, don't ever do that in general. It's the big, life lesson about that. But if you have an ultrasound done with an MFM or in an MFM office and they bring you back, ask why. Yeah. Because oftentimes I'll have people come back because I just can't see some of the details. It's almost always the heart and the face because they'll be I'm tucking my neck. They'll be tucked in. We're just
so dependent on their position. And, it doesn't serve anybody. our exams, the company I work for now, our exams are an hour long. And going past that hour, one, is not good for our bodies as sonographers. No. It's not good for the baby, and it's not good for you as a patient. So there is no reason to go to scan for hours and hours. We're just not doing that. It's not good for anybody. So you know what? We scan for the allotted time. If the baby doesn't move, we have you come back.
Yeah.
We don't stress about it. We're like, no. And sometimes they just don't.
Yeah. Okay. We've literally gotten through two questions. What's OBGYN and what's MFM?
Okay, well,
I love Marybeth.
They were big ones.
They were big ones. And all those things are things that we needed to talk about anyway. So it's perfect. Mm-hmm. Okay. Question number 3. How does a provider come up with the due date during pregnancy?
Oh, I think patients struggle with understanding this as well.
Yes. There's a whole YouTube dedicated to what is my due date, by the way.
And there needs to be. Like, there should be, because I find patients are very confused by this. But typically, it is the first day of your last menstrual period. It is not the last day. And patients get a little confused. It is the first day of your last menstrual period. And then we do like it confirmed by an ultrasound, especially your anatomy scan. And I will ask patients, what's your due date and what is that based off of? Is that based off an ultrasound? Is it based off your first day of your last menstrual period? Has it been confirmed by an ultrasound? Things of that nature. But I think it is, and we generalize, right? Like, we have to find a way to have like a common number. So we are, we pick a date that's 40 weeks pregnant. And then there's difference of, preterm, term, post-term. Mm-hmm. There's a lot of that, but
all of that.
We have to quantify it, and we have to take a date. And I believe it's less than 10% of babies are born on their due dates. Is that the statistic?
Oh my gosh. I mean, probably. I
think it's about
I don't know anybody who really says, and I think that people have the expectation though. They hear that that's their due date, and all of a sudden everything's, cleared on their schedule for that one day. And
I always feel like it's like, no. It's kind of like welcome to parenthood. Like, you can plan all you want, but just gotta be flexible.
Be flexible.
Like, just be flexible. Like, we're going to put this date out there, and that's our goal.
Yeah.
But things can change.
Things can change. Be flexible. Again, it's the baby show. Mm-hmm. We're just kind of like, I always say it's a baby show, and we are kind of translating what we see sometimes and telling the parents, here's what we see in utero, and here's the recommendation based on what we see.
Yep.
So please don't be mad at us for the change in plans. We're just telling you what the baby's telling us. Right? I like it.
That's what we're doing.
And for the due date stuff, there is a YouTube on what is my due date. There is a free download for that too that goes through exactly what Marybeth was talking about. First day of the last menstrual period, ultrasound, and then when it should be changed or you should keep it the same. It's like a step 1, 2, 3 to help people understand it. So check out that download.
I think too, people think that it gets a little confusing if they've been told their baby is big or small at the end of the pregnancy, that changes it. That does not change how old your child is. It changes how the size. Or the weight, or the big, it changes that, but it doesn't. It's kind of like if you have a 7-year-old that wears 10-year-old clothing. They're
still 7.
They're still 7. Yeah. They're not 10. They're just a bigger size.
Your analogies are just so spot on.
Well, it's kind of like, you got to make it easy. If you can understand it in simplistic terms, it makes sense to patients. So I've got a slew. I've given you multiple.
Oh my gosh, this is great.
I didn't realize I had so many.
Well, I didn't realize we did not plan this either, but I didn't realize how it's like, so I love that you're saying things that you see and you hear that patients commonly have topics that are confusing to them, because I'm trying to think when I make something for people to see, like, I think this is something that they would benefit from. Yeah. There's also one on how big is my baby? Yes. And it goes through step by step, an actual like ultrasound, what the percents look like, what that means. Mm-hmm. And when you see gestational age or your EDD, that's your estimated due date. And then you have ultrasound gestational age, which doesn't mean
get very confused by
there's so many numbers.
I watched that video. It was excellent.
Did you? Okay.
I did. I really enjoyed it. I was like,
good.
Yes.
Okay.
Yes.
Okay.
I did.
Stamp of approval.
Because if you are looking at the report, you'll see the estimated due date and then the ultrasound due date.
Yes.
And I think people, especially if you have a bigger baby, they're like, I don't think the baby's going to fit. Like, I don't think the baby's going to get out. Because I admit, as a pregnant woman, I was like, I don't think I want to have kids. Being pregnant, 9 months pregnant, I'm like, I don't think I want to do this.
People say that because
it's scary.
Every pregnancy ends, right? Yeah. I have people that are the same way. They're like, wait, I'm not ready. I'm like, but you've been preparing for this.
No, it doesn't feel like that.
Okay, yeah.
No, it doesn't.
Kind of slaps you in the face. Okay.
But I think they think, the baby's going to be too big, so the baby must come early. So if that happens and we just have a big immature baby, like we don't have their lung development, their brain development, there is so much that happens after 36 weeks, 37. Like we want to give them as much as a chance of having that brain and lung development as we possibly can. So we want to deliver big babies early because then we're setting them up for a worse transitioning time, especially for their brain and hormone and lung development.
All the good stuff.
All the stuff.
All the good stuff.
Mm-hmm. Yep.
All right. Question number 4. When is a pregnancy considered term?
Term. I always tell people, this may or may not be right. I always tell people that they will not stop your labor if you go into labor starting at 37 weeks. Typically before then, that would be like an early or a preterm labor, and they're going to try to stop it. But after 37 weeks, if your body goes into natural labor, like if your water breaks, things like that. I mean, there's only so much you can do to stop a labor anyways. Like if you have spontaneous rupture of membranes at 34 weeks, and that baby comes, right? But I've always used like 37 weeks. Like that's kind of like they won't stop you.
You're very correct.
Term. Am I?
Yeah.
Okay, good.
30. There's different.
I haven't fact checked that for a couple of years.
These are all, again, I do it out of the blue. But 37 weeks is 37 weeks and 0 days exactly is the first time there is a label of term. We call it early term now, but it's still considered term. Like you said, if you go into labor at that time on your own, no one's going to stop it because it's not considered a preterm labor, right? I love it. Good job, Marybeth.
Yep.
All right, question number 5. What is the normal fetal heart rate?
It depends on the gestation.
I was going to say, this is going to be hard for you to answer with just like
oh my God, my fetal echo is going to come out and me. So
educate us a little bit on
because
I feel like I just want to sit back and take notes right now. Okay, go.
Because the heart is immature in the first trimester, it can be really 100 to 190. There's a bigger range. It tends to be slow very early. It's like around 5-6 weeks because it's just getting started. And I really feel like I just want a heartbeat. Like I just want a heart rate. I just want to see those cells starting to pump. So it can be lower. And then in the second trimester, about 120 to 180 is usually the average, but that depends. Like I think patients, this is a number that they can easily quantify. So they tend to focus on this number.
True.
And I get it. It's quantifiable. Yeah. It's very simple. It's a very simple number, but there's this huge range. So, and a lot of people base gender. Oh, is it high? I'm like, no. Just get that out of your head. Does not.
Myth.
Not fact. Not fact. I do believe that was a study done in the 80s on 10 patients.
10 patients.
10 patients.
So in the world of statistics, that's a very small cohort.
It's like, doesn't count.
Yeah.
It really doesn't
10
count.
people.
10 people. I'd have to fact check that one, but I had read that somewhere. So, but the idea is that, if you have this range of 120 to 180-ish, if you have that range, that's all falls within a normal range. Now, if the baby is moving and stretching and is moving around, the heart rate is automatically going to be higher. Like if you are climbing up a mountain, your heart rate's going to be elevated.
Yeah.
If you are relaxed, if you're sleeping, if you're laying down, the heart rate's going to be a little bit lower. So it depends on when we measure it, at what activity point the baby is what the range of the heart rate's going to be. But we're always looking for a low heart rate. We're always looking for a regular heart rate. We want a nice regular rhythm. And, obviously we don't want it above 190, 180, 190. And then we're moving to like SVT. We don't want that. You know? So we want a nice normal range, we want like, if a baby's moving, I expect the baby's heart rate to be high. If I have a baby that's moving like crazy and it's like 110, I'm a little nervous. Like
it doesn't correlate.
Right. I'm like, and you have to kind of think of it like in simplistic terms. Like if you are moving, your heart rate should be up. If you're sleeping, your heart rate should be down.
So would you agree? Because I usually use the correct answer is this for a nice range of 110 to 160 because that's like our baseline. And understand too, when Marybeth is talking about being in the 180s, that's when the baby's moving and doing stuff. And the heart rate can jump up, but it should come back down to be in the 160s, lower end of 110s.
Yeah, I think 180 is above average.
Yeah, okay, thank you. Yes,
I definitely
she agrees.
Yeah, I definitely do. But I commonly see 165. That's not abnormal.
But you would go back and check and make sure it doesn't go up.
I will check 10 times.
Thank you very much.
The patient
That's a skilled ultrasonographer.
I am checking. I'm like, oh, look at that pretty face. I'm watching the heart. I'm not watching that face. I am deflecting, but I'm also diagnosing.
Well, not
Same
diagnosing. I mean,
In my brain.
in your brain.
In
Your
my
brain
brain.
diagnosing.
Differentials.
Which is the best thing about a skilled ultrasonographer is making sure or trying your best to have that differential. And if you see something, going back and checking it again, particularly for the heart.
Yeah.
Because that baby's going to move. And then maybe you get a better picture if you have a better position.
I always tell patients, because sometimes they're like, well, at my OB office, they said the baby moved too much and couldn't get anything. I'm like, okay, I love a moving baby. Because every time that baby moves, they show me something else that I didn't see before.
Opportunity.
And I want that baby to look normal in every position they can put themselves in. So it's very hard to make abnormal look normal, but it is very easy to make normal appear abnormal. Does that make sense?
It makes sense to me.
So like you can take this abnormal structure in the baby or normal structure and the baby's in a weird position and it can look bad, right?
Yeah.
It can look like, ooh, maybe that doesn't look good. Like maybe the hand's not normal. And then the baby's like stretching like, oh, just kidding. It's just like, okay, I can delete the last 10 pictures I took for you.
Like when they sit crisscross applesauce.
Yeah. And you're like,
and their
are the
ankles
feet
turn
clubbed?
in.
Are they? And I tend to be like, oh my God, it's arthrogryposis.
Yeah.
And then the baby, I'm like, okay, no, it's just a clubbed foot. Okay. Oh, maybe both are clubbed. And then they straighten out and you're like, okay, they're fine.
Yeah.
Like that really is.
Yeah.
Like, but you're like, and I tend to be a little bit like Chicken Little. Like I always think this guy is falling.
Yeah.
Right. So I always think there is something wrong with this baby and I have to find it.
Until I prove that it's not.
Right.
So like if Marybeth and I were working together and she were to have taken a still frame picture, because ultrasound, you can get
you do clips,
videos.
you can do stills. We do a lot of volume rendering now.
If she had a picture and I saw the ankles turn in and then later she didn't show me the lower bones of the leg and the ankle in another position, I would ask her to give me another image or try to get a video.
Like, hey, did you see those legs unfold?
Right.
Hey, could you see that the foot was a 90-degree angle of the calf of the shin? Like, can you see that? And that is all stuff that you have to look at and you have to think about. Like, super cute. Is it normal?
Okay,
is it just a positional thing?
I'm going to do this to Marybeth, and I haven't done this to anyone, but I have to. Okay. Clinical scenario. Are you ready?
Yeah.
Okay.
Lay it on me.
Lay it on me. All right. We have a patient that comes in.
Okay.
She is getting her like an 18-week scan.
Okay.
Because at 12 weeks, she's a poorly controlled type 2 diabetic.
Okay.
Very slender.
Okay.
A1C is like 12.
Oh,
okay.
Shit. Yeah.
So already.
I'm already thinking a heart defect. I'm already a heart defect.
She's already there. Okay. So.
Especially if they're poorly controlled in the first trimester during organogenesis.
Right. So 12 weeks, had a nuchal translucency. Everything appeared fine. Some limited views, whatever.
Okay.
But the nuchal was fine. So the thickness of the back of the neck is normal. Comes back in 16 weeks for an early anatomy ultrasound as best we can see because she's so diabetic.
Right.
For people listening, we're not letting her wait till 20 weeks.
Yeah, we do. We go early.
Early. Because if there is something wrong with that heart, we should be able to maybe see something.
Yeah, I think with a lot of, with our machines and skills, we can.
Yeah.
We really can.
And plus, I just want a nice sweep of this baby at 16 weeks.
Yeah, absolutely.
Comes in. Ultrasonographer scans, gives me a lot of still frames, very few videos, right?
Yeah, I don't like that.
Okay, I don't like that either. I notice on the kind of sagittal or like the sideway views, I can't see the lower part of the spine well, particularly when the bladder pictures are being taken.
Right.
And then I see a femur length, so we're measuring the upper leg bone.
The thigh bone.
And as the thigh bone is measured, I can see the other thigh bone. Do you see what I'm saying? Ooh. Thigh bones in fetuses typically don't, like, I have my legs crossed right now.
They shouldn't touch like that.
Fetuses, like, they might sit crisscross applesauce where the lower parts, like below the knees, cross.
But the knees are separate.
The knees are separate.
Yeah.
Have you ever in utero seen two thigh bones on a fetus that's 16 weeks crossed?
No, I don't believe so.
They just don't anatomically do that, right?
No, cross at the ankles a lot.
Ankles, yes.
Not
but
even
we're talking
really knees.
No.
Fetuses don't really even cross their knees.
So this was, to my reading it as an MFM trained physician, that's not right.
No.
Okay? Something's not right with that.
No.
Ultrasonographer did not pick up on this.
Oh.
And I said, hey, can you go back in and see if you can...
And they didn't see the sacrum or the lumbar.
Okay. Can you see if you can give me any more pictures of the lower spine?
Yeah.
And you couldn't see the lower spine. So there's something. So what are you thinking this is? Poorly controlled diabetic?
I'm thinking some kind of caudal regression syndrome or
And it was
cyanomegaly or
some
kind of defect that hits the sacrum. Like stops.
Yes.
And it all like it doesn't form correctly at all.
There's no bones of the sacrum. It's caudal regression.
It literally means caudal regression.
Yeah. Sacral agenesis. And that is common in not common, but it is more common.
Yeah.
You can see it more frequently in poorly controlled diabetics. And my clinical brain picked that up.
Yeah.
Their clinical brain didn't pick that up. However, their ultrasonographic brain didn't pick up the fact that you have multiple femurs crossing each other at the level of the bladder.
Yeah. If you think about like even as an adult, like as we cross our legs, we're crossing it almost in the distal portion of our femurs, right? So you're kind of like, to do that is abnormal.
Yes, that is abnormal.
And you really have to like think like as an adult, can I do that? Like, and that's a lot of like when we talk about antenatal testing, which I know we'll jump into a little bit, but like what should a normal baby do? They should stretch and they should roll and they should kick and they should punch. They should feel good. Like how do you as a person, you should feel good.
Same. I stretch.
You should feel good. You should stretch your hands. Like, so if you think about like, that is not a normal position for a birthed person.
Yeah.
Like, it shouldn't be normal for a fetus either.
Yeah. Okay. Yeah. I love that. Thank you for letting me give you that.
I know. I'm glad I got the answer right.
And that was like.
Does the baby have a heart defect?
The heart, the heart was fine, but it was something else.
Yes. Yeah.
Question number 6. I mean, we led right into this too. What is antenatal testing or fetal well-being testing? As best as you could explain it to someone who is going to have to ask their doctor about it, maybe.
Yeah. Well, I like to think of at the end of pregnancy, we're not like, well, you've made it so far. Congratulations. We ramp up. We are ramping up here. So like people that do need twice weekly testing, it's all about well-being check. You as a patient should be doing kick counts at home, things like that. So a lot of it is just we are popping in to say hello to your baby and to make sure that they are doing all the things that a healthy baby should do, So by ultrasound, we call it antenatal testing, but it's biophysical profile or BPP.
Another acronym we use.
We use that. And I think it's good for patients to know all of those things are really the same thing.
Yeah.
But, it's a 30-minute timed test. And we are looking for the well-being of your baby. So we're looking for stretching. We're looking for kicking and punching. We're looking for good amniotic fluid, which tells us how well the placenta is functioning generally, or if your water's broken, things like that. And we look for what we call practice breathing. So practice breathing, like babies are not breathing. They're like little scuba divers.
This freaks people out.
So they're not breathing. Yeah. They're getting all their oxygen.
Breathing.
They're getting all their oxygen through the umbilical cord. So, but they are doing practice breathing. And when they are practice breathing, correct me if I'm wrong, Dr. Hill. When they're doing practice breathing, that means that they are not in a coma-like state. They have good oxygen in their brain. So because they have good oxygen in the brain and their body feels good, they do these things that help with maturity and are moving oxygen through their body. Now, when a baby goes into distress, breathing is almost the first thing that stops because their body is like, man, I got to like preserve all my oxygen in my brain. So I got to stop breathing. I'm going to stop practicing this breathing because I have to preserve my oxygen. Now,
on the flip side though, right? So when people hear that, don't freak out yet because since babies go through sleep cycles.
Oh, they cluster breathe.
So yes.
We don't see it all the time.
Which
is why the test is 30 minutes because we are attempting to catch a cluster of breathing.
Yes.
So they don't do it all the time. So sometimes, you might go in for your antenatal testing. You might be in and out in 5 minutes. That baby's moving, kicking,
They caught
stretching.
A good cycle.
Boom, we're done. The test is up to 30 minutes. It does not need to be a full 30 minutes. So if we're just doing that well-being check and your baby has done everything, now I like to take a few minutes, like, let's see if we can get some extra pictures. Your baby's already passed this test.
Because Marybeth is so kind.
Overachiever of a child, right? Like, okay, let's play for a few minutes. And then I feel like patients still get to see their baby, which is kind of lovely. But I can do all this. I can do my job and this
because you're waiting kind of, right?
But if we're waiting for breathing, that happens too.
And so if you don't get the breathing, talk to your provider about your next steps. And please make sure that they explain to you that you're probably and should be going for a non-stress test or some continuous electronic fetal monitoring, which those are the two belts that go around your belly, the top one that looks for contractions, the bottom one, they'll put it on the baby's heart rate and look at it for a bit of time. Because if your baby was in a sleep cycle for that entire 30 minutes, which can happen.
Totally happens.
Happens all the time. I mean, not all the time. It happens
frequently, though.
Frequently,
I would say frequently.
So don't let that make you too nervous, but just make sure that they don't send you home and not evaluate something else like putting the belts around your abdomen.
Right. Yeah. And a biophysical profile is scored. So the baby does get 2 points for everything they do. So your goal is, the baby's goal is to get an 8 out of 8 points. So we get 2 points for the practice breathing, 2 points for movement, 2 points for gross body movement, like a stretch, and then 2 points for a fluid. That's a pocket of amniotic fluid more than, is it 2 or 2.5 centimeters?
2 centimeters. 2
so
centimeters
2
deep.
by 2.
Technically, 2 centimeters deep, and it has to be at least 1 centimeter wide.
Yes.
We love to see a 2 by 2 pocket, and I'm doing with my hands like deep and wide. But by definition, to say that the pocket is a legit pocket, it has to be at least 1 centimeter wide.
Yeah. So, those are like tiny little nuances of the exam. And I think patients, they get concerned, like, if they hear they didn't pass. And I always tell people, like, so it depends on why you don't pass. Yeah. If your baby is stretching and moving and we have good amniotic fluid and I just don't see breathing, I'm not super worried yet because your baby's still acting like a healthy baby. So we're going to put you on the non-stress test, and the NST essentially negates the breathing portion of that exam. Great. If you come in and the baby's breathing and moving and you have no fluid, today is your baby's birthday, right? Like,
depending upon how many weeks you are.
But if you think about it, depending on what part, if you were in your if you were at your last 6 weeks, 4 weeks of your pregnancy and you're moving into antenatal testing, why don't you pass? If I can't wake your baby up, I am concerned.
Yeah.
If you have no water, I am concerned. Yep. But if it's the breathing, as long as I have everything else, I'm not super concerned.
I love it.
I like to kind of break it down. Like, it's not all or nothing, right? I like to break it down a little bit.
I love that. Yeah. Simplicity, right?
And really remember that NST, those bands are what you're essentially wearing during labor as well.
Yeah. So if somebody, if you've ever had a kiddo before and you're in the hospital with the 2 bands, it's the same thing. Same bands.
Same bands.
Question number 7. How does an ultrasound estimate the weight of a fetus? She loves these questions.
I do love these questions, actually.
Do you know, though, and I've asked people that are not ultrasonographers, right, that are just, it's their first pregnancy, and some of them actually get this pretty right.
Oh, good. It means they're good like they've looked into it.
They actually watched the videos.
Okay. I was like, maybe they haven't subscribed to your YouTube channel.
That's right. So how do we get the weight?
We measure the head. We measure what's called the biparietal diameter, meaning like right to left. And then we measure the head circumference, like if you were going to measure your head for a hat. Yep. We measure those 2. We measure the belly, like if you were going to put a belt around the baby's waist. And we measure the thigh bone. And so those 4 measurements go into a calculator and magically, which is because it feels magical.
Yeah, it does.
Spits out what we call the estimated fetal weight. And so we do the best that we can. Again, when a baby is bigger, there's more variables in our measurements and how good we are. I hate to say how good we are that way, but like
how good the calculation is.
It really is. Like, so if you think about like, if I need this plane for the baby's head and the baby is in the mom's pelvis and so tucked, I might be off angle a little bit because I just can't get to that spot. So the measurements, we have a bigger range of error. Yeah. The further along, because they're just harder to measure.
Yeah. And so what Marybeth was doing too is kind of like tilting her head for anybody listening and not watching. The way I describe it too is I have a little stuffed animal.
Not the doll?
Not the doll. The dolls, I know. You did watch the video.
I did watch it.
I had to borrow that doll because I don't have any Barbies at my house. So, but it's more of a stuffed animal. And I just show them with this stuffed animal laying flat. If I did slices like this animal is a piece of bread and I'm going to take a slice, I could get a nice even slice.
Right.
If I squish this stuffed animal into a little tucked in cute ball, right?
Yep.
And now I try to get those slices. It is very difficult, and I could over or underestimate depending on the position of that stuffed animal, i.e. the fetus.
And I always think, that the head and the femur as a bone, like femur. Oh man, I could do that standing on my head, right?
Yeah.
Like that's the easy. That's our it's most linear.
Yeah.
It's the least difficult. Like that I can measure easy peasy.
The abdomen.
But the head and the abdomen, but especially the abdomen. And
yes.
I do believe that of those measurements, when we follow Hadlock and Williams, those are like who
that's the
calculator, like who made those calculations. In the early pregnancy, the femur is a little more accurate for gestational age, like when you talk about like that anatomy scan and maybe even a little earlier.
Yeah.
But, just because we measure the baby in 4 parts, later on the abdomen actually has a bigger portion of that calculation. So you think each one of those 4 parts is 25% of the calculation. That is incorrect. It is like the abdomen has like 40%. And then the head and the head has another one. And then the femur, like it changes for gestational age. So
some people use the arm bone too.
Yeah, the arm bone is great in the first trimester, especially for genetic, for a genetic ultrasound. It really tells us a lot, but it doesn't, the arm bone isn't in the calculation for
all of
the
them,
estimated fetal weight. It's not in all of it. So
it's confusing.
So if you think about like the baby is all smushed up in there, and especially if they're curled up into a ball or they're in delivery. I always say, like the baby's head down, face down. I'm like, launch position.
Yeah,
they're in launch position. Right? So it's like, especially like your late term.
Yeah.
That is the position we want them in. It is not conducive for AC measurements, especially for abdomen.
Circumference. Yeah.
And so that can skew the weight higher or lower inadvertently.
Yeah.
And so you kind of like,
always,
I know most of us sonographers don't actually like late-term measurements because they don't feel accurate.
Yeah.
And I will tell the patients, like, your baby's not in a great spot, so I'm not confident in my measurement. In my measurements. I will do everything I can, but again,
we can only do what we can do with the tools we have. And if you think about it, like if we stand up right now, like if you have a pair of tight pants on, right? And I'm standing up, they might fit beautifully. And I sit down and I lean over and I'm like, these are not the best pants for eating Thanksgiving dinner.
Yeah.
Right? And think about that. The fetus later on is not straight out. Like if you look at your 20-week ultrasound, you can almost see the whole fetus in a beautiful picture. Yeah.
And then you're
straight.
Like, it's just a face.
Yeah. And then as you go forward, you get the cute chubby cheeks and whatnot when you can see the face if the fetus is in a good position, but they're tucked in, right?
Yeah, they are.
Because they're making this little nuzzled space inside this uterine cavity. And they're tucked, right? Yeah, so you're going to have these little, I call them my little fat rolls, but the baby's abdomen could look much bigger than it actually is.
And we really like it to be like a nice circle. We're very like, heads are ovals, right? We're not Charlie Brown, so they're not round like basketballs. So they're a little ovally, not too oval.
Not too ovally.
Yeah. And we like,
you don't want a strawberry.
Right. We don't like strawberries or clovers.
For those ultrasonographers
we don't
listening.
Like any of those. No lemons.
We are nerding out right now on all the fruits that they talk about fetal
So that's what it is. Hey, you got to make it easy.
I know.
So we like bellies like basketballs, really round. So if they if you lay on your side, we can get them like ovally, and they're harder.
Yeah, it's harder. It's harder.
It's just harder.
All right. Question number 8. What makes up amniotic fluid?
Oh, well, it's really urine.
Yep. It's baby urine, right? Yep.
And I like to tell patients, like at the beginning of the pregnancy, the maternal body has made this for the baby. Like, we love you so much. Here's some amniotic fluid. Mm-hmm. And then around 15 weeks, their kidneys then start to take over the production of that amniotic fluid. And so for your anatomy scan, if there's good water around the baby, we know at least one of the kidneys are functioning. So, but the baby, man, they live in a bubble. They eat, drink, pee in a bubble. It's like the ultimate in recycling.
It's their little happy place.
I always tell patients, you did it, turned out just fine.
Yeah,
see, we all did it.
We all drank our own pee at one point.
Real. Yeah. It's like saline fluid.
Yeah.
It's not real, a little musty.
So somebody asked me one time when I asked this question, they said, I think it's made up of sugar. And there is some glucose in there, you'd have to think, right?
Okay, yeah, of course.
But I had to say, it doesn't taste sugary.
Yes.
Not that I've ingested it on purpose.
No, but accidentally. I think every good delivering OB
has had a splash of amniotic fluid just go down your face, and you can't. It burns your eyes too because it's like salty. I don't know, but it just is. It does.
Salty.
And I had goggles on and everything. It didn't care.
God.
Just all the way down.
I did work with an OB. She's fantastic. And she said, it's a little musty in my mouth.
A little musty in my mouth. That I've never heard.
I love her so much. She's so amazing. But one of the reasons
Musty
I love
in my
this,
mouth.
she's a great OB for me.
Yeah.
A great friend.
Yeah.
A great provider.
I love it.
And
I love it. Musty. I'll never forget that.
A little musty in my mouth.
Never forget that. Never forget that.
She's local here.
Oh, man.
Still practicing.
Love
Musty
it.
in my mouth.
Love it. All right. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
Absolutely everybody.
Thank you.
I mean, I don't care. I don't care if it's not in your family. It's got to start somewhere. I don't care if you're 18.
That's right.
Everyone should get it. I also think, though, everyone should understand what that testing is for. So, in your handout of like genetic screening, I think people are confused by what that means.
Yeah.
And so I think everyone should be offered it. Everyone should be counseled on what a positive result means.
Yes.
I think that's also something.
And they should be counseled on the test before it's sent.
Oh, 100%.
And do you feel like that happens on average, just from people you know?
I think it's dumbed down as we'll be able to find out the gender. And we're not a society that needs to be dumbed down anymore. I think of my grandmother and, she's like, as the doctor said, we don't live in that society anymore. And we are educated people. We should be educated about our bodies. What is that test looking for? What is that and especially like the NIPT, you're really only looking for a few things. It doesn't catch everything.
Yeah. So NIPT, non-invasive prenatal testing,
or NIPS,
non-invasive prenatal screening.
Yep.
So your provider's office might use one of those terms and not tell you what it means because they're so used to using it in their colloquial vocabulary in their day.
Nice word. Nice.
Colloquial.
Oh, wow.
Some days I use big words.
Scrabble with you ever.
But we call it non-invasive because it's a blood test.
Yeah, and they pull the baby's DNA from your blood.
Correction. They pull your blood, spin it down, and they're trying to see the cells that you and baby share at the placental level. They are syncytiotrophoblasts.
Oh, look at you.
But that's I would explain it that way, though. I would say we're looking for the baby, right? You're trying to check out the baby.
Yeah.
But sometimes, and this is why everyone needs to know about the test before it's sent, if it comes back abnormal, it could be something going on with the fetus, something going on with the placenta, or the patient themselves.
Correct. And there's a lot in there.
A lot in there. And I've talked before in a different one, we helped to diagnose a concern for maternal breast cancer because everything came back abnormal in the result.
Wow.
Trisomy 13, 18, 21.
And you're like, whoa. Hold on. Something's wrong.
Something's wrong.
Yeah.
And the patient had complained about a breast lesion and was being worked up for breast cancer at the time.
Yeah.
Had missed appointments, though, because was like, it's probably nothing.
Yeah. And I'm pregnant.
And maybe my breasts are tender or whatever, right?
Yeah.
These tests are so huge. They actually have a new video, and it just came out very recently, within the last month. And it's on ACOG's website.
Okay.
ACOG.org, I believe.
I think it's so, yeah.
All right. So go to the ACOG website. I'll put the link down below for a video that they just posted that explains cell-free DNA screening, which sometimes is called non-invasive prenatal testing, NIPT, or non-invasive prenatal screening, NIPS. Some people even call it NIPS.
NIPS, yeah. And I think if you think about the reason it's called non-invasive is because it's a blood draw.
Yeah,
it's not an amniocentesis. We're not putting a needle in the maternal abdomen to check for that. That's why it's non-invasive.
That's why it's non-invasive.
Because it's the blood draw.
So I try to not use the term just non-invasive prenatal testing or screening. I say, would you like to do cell-free DNA screening?
That's a great,
It's also called these other things because there was a bulletin, and in our world, there are these bulletins that kind of guide us for standards of care and just the taking all the data and putting it into one spot. Technically, if you say non-invasive prenatal screening, that also includes first trimester screening because it's non-invasive.
Oh,
so that term has become an umbrella now, and then you have to specify which type you're doing.
Yeah.
Most people use them interchangeably with cell-free DNA screening, just so you know.
Yeah.
So, and the cell-free DNA, it's taking the maternal blood, the patient's blood, and it does have to extract. The fetal fraction is what they call it. And that's the part of the cell-free DNA that's fetal. And then that number needs to usually be good enough.
Yeah, you have to be able to capture enough, which is why you can't do it at 6 weeks. You have to wait past a certain, which goes back to if you're dated properly.
Exactly.
You know, if you have your good due date and you know you're over 10 weeks. Sometimes even if you're heavier, they want to wait a little bit longer. So you have more of that baby's DNA in your blood.
And
so
being on a blood thinner can actually affect the results.
Oh, that makes sense. Yeah. That's okay.
I mean, there are a lot of things. So if you're just going to your provider and they're like, here, go get this test done, please just ask what they're sending it for. The other kind of caveat, which Marybeth brings up, is it tests for technically only 3 of the most common chromosomal abnormalities.
Not everything.
And it's looking for the chromosome itself. So we're looking at mainly chromosome 13, 18, and 21.
Correct.
And chromosome 21 abnormality, if there's an extra copy, we call it trisomy 21, which is Down syndrome. Now, to be aware, it's a screening test. It's not a diagnostic test.
Right.
It's these 3. Here's the little new thing that's happened. It can look at gender.
Yeah.
And so some people call it a gender test.
Right. Because, you're looking for abnormalities along the sex chromosome.
It is.
It's not for funsies.
It's looking for presence of the Y chromosome, technically. And then it's trying to then look for issues within gender chromosomes.
Right.
The problem with that is those tests aren't as good, statistically speaking, as the ones for trisomy 13, 18, and 21.
That makes total sense. Yeah. So you get like a high, more false positives.
You could get more high false positives. Right. So then it also looks for DeGeorge syndrome, monosomy X, triploidy.
Yeah.
But not every test, only certain brands.
Yeah.
It gets so confusing. So if you don't ask your provider which test they're sending, number one, you don't know what they're screening for. It should be testing for those main 3,
it should be.
13, 18, and 21 for each of those chromosomes and looking at if there's too much material of that concern. Yeah. So like if you don't know what it's testing for and then you get a call from the company or a medical assistant at the front desk that your test is abnormal, well, what part of it's abnormal? Oh, you're going to have to come in and talk to someone about it.
Do you feel like most OB physicians have enough practice with these individual labs to provide counsel to their patients in this? Or do you feel like this is more high risk, like what a high risk doctor is better at knowing?
Right.
Because you don't know what to test for. Like, it's not testing for everything. You have to know what to test, what you're looking for.
Right,
so you might choose a different brand, knowing like this patient has a history of DeGeorge. I'm not going to send it to this lab. I'm going to send it to this lab. Like,
that's a good question.
Especially for people that have that kind of family history.
If you have that kind of family history, you definitely should see a maternal fetal medicine specialist and a genetic counselor, because a maternal fetal medicine specialist is not a genetic counselor unless they are also boarded in genetics.
Yes, fair.
Which they can be. The percent of maternal fetal medicine doctors that are also then subspecialized further and do an extra training and certification in genetics is a very small percent.
I was gonna.
Right. So most maternal fetal medicine offices, if you have a genetic condition running in the family or something we think could be inherited or passed down in the family, we should be getting you to a genetic counselor separately, unless I tell you that's in my wheelhouse.
Yes. Yeah.
So for basic, I'm going to say Down syndrome screening, because that's the one we're most concerned about, I would say.
I think statistically it's the highest one, right?
Correct.
So that's why
correct. That is the test that OBGYN offices should be able to counsel and screen their patients for when the patient does not have any genetic history that they want to talk about. So I do believe that an OB provider, if you're caring for OB patients, whether you're a nurse midwife, a nurse practitioner, a PA, or an OBGYN, obstetrician, then yes, you should be able to comfortably counsel them, send the screening test, and then if it comes back abnormal, you send them to a genetic counselor.
Right.
And then maybe an MFM as well for the ultrasound. That is absolutely that is needed for the ultrasound.
Yeah. I think that's a basic step of care.
And then the other part too is you had mentioned the test that's being sent. It is currently recommended to just send for those 3. Okay. The gender on top of it is fine, but you're not meant to screen everyone for monosomy X, which is Turner syndrome, or DeGeorge syndrome.
Right.
But some institutions and offices, most OBs don't know. They just say, okay, send cell-free DNA screening.
Right.
And someone, a nurse, a medical assistant, a front office staff, checks a box and sends it.
Right.
And the patient doesn't know what was sent.
Right.
The staff has no idea unless they've had training. And then the OB provider never directly probably checked it themselves. Maybe they did.
Yeah.
But that's what's happening.
They got a lot of stuff coming in, though.
They do.
It's
They're
so hard
busy.
to keep so track of that.
They're busy.
Yeah.
But my, I guess, pet peeve with this is if they're not doing it, who is?
Right.
Nobody.
Right. And they're expecting, I think, too, what happens with patients now that we have these amazing access to our own EMR, our own electronic medical records. We have apps. We have blah, blah, blah. So
portals.
Sometimes patients are logging in and seeing their results.
Yes.
Without the physician.
Right.
And I believe it's a law. Is it a law in Arizona that patients need access to their labs within X amount of time?
I don't know the answer to that.
Just told me that
I'm not sure.
There are some states that require results to be released within a certain amount of time. So if the physician
from the time they resulted,
yes,
okay.
So it basically is meant to be like if it's sitting in a physician's queue and they haven't read it, the patient gets to have access to it after a certain amount of time. And as a physician, you should have, let's say, up to 48 hours to review those results. And if you don't, the patient should have access to it. So I think a lot of times patients they get
the information before the provider does sometimes.
Right. But also, I think they have this, some patients are, well, no one told me it was abnormal, so I assume it's fine. Right? There's some loss of communication there because they're expecting people to go over the results. And if they don't go over the results, like there's got to be some that are just lost.
Right.
Just lost.
Just lost. And so this is the part, I guess, as a provider, I've worked in places before where you feel like you don't have as much time with patients.
Right.
And you want to inform them, but maybe your employer's like, nope, you got to see 20 more patients today.
Right.
You need to go faster.
Right.
So my thought now is how can I help get information to patients even if I'm not their direct provider?
Yeah.
Number one, I can teach them where to go.
Yes.
So I think this website that ACOG has put up, which is our kind of society for obstetricians and gynecologists. It has great frequently asked questions that patients can go to, great patient resources. So I'll put that down below. The Society for Maternal Fetal Medicine also has a bunch of stuff for patient information. So I'll put that site below too. It's smfm.org. Those are great places to go. And even if your OB provider doesn't tell you to go there or give you the information, you as the patient, I as a patient, when I'm a patient for my cardiologist, my pulmonologist, my whomever, I have to advocate for myself all the time and do my own background research. My job right now for pregnant people that are listening, I want you to know the resources that we've vetted, that we've looked at, that we know about, that we can share with you, and then also give you and fuel you with the ability to ask these questions.
Right.
So that when you go in for your Down syndrome screening, number one, make sure they offer it to you.
Right.
Number two,
and understand why it's being offered.
Yep.
And
what they're sending.
Exactly.
And did they send it all?
And if they can simply explain it to you and you understand it and you can teach it to somebody else, that means you do understand what it is.
And you're having an impact on other people down the road. You're paying it forward.
Right.
Yeah.
So all of that.
I love that. I love that. And if ever you need more and you want to have a consult with me, I can do that too. I don't have to be your direct person you see on a daily basis. You can get online. You can book an hour consult with me.
Yeah.
As long as you're in a state I'm licensed in. So check that.
But sometimes you do receive so much information in physician's office. And I think statistically, we only remember 30% of what people tell us.
That's about right. Yeah, for sure.
So, which is why we always say take a partner or take somebody with you to also hear.
Take notes.
Take notes. But it is a lot, you're already getting so much information.
Yeah.
So sometimes there are things that I should have asked I should have asked her about that, or I should have asked him about that, or, I'm thinking about it later. So it's a great resource to be, there is someone else I can reach out to.
Yeah.
It's awesome.
Yeah. And to always, I like when patients would leave the office, and that's by when I visit with people virtually, there are handouts that they will receive, right?
Yep.
And you can download them whenever you want. You can put them on your phone, you can print them out.
Yeah.
Something tangible.
Yes.
So that later when you're like, oh, what was that word she said?
Yeah.
And then you can look it up and
don't feel bad to say, I need you to spell that.
Yeah.
Right?
Not a problem.
Spell it out.
Yes.
I mean, I am constantly
Spelling
Googling,
things.
writing things down. And especially if I don't quite understand it, I'll just keep going over it until I do.
And the words that we throw at patients a lot are very complex.
Yeah. But they're common for us.
They're common for us.
Sometimes, and I don't want to say dumb it down, but sometimes you do need things explained to you in a very simplistic fashion.
Yes.
And if you can understand it simplistically, then you can add on those layers of complexity of what the real word is, if you will.
Okay, so I want to, we have one more question for that. Oh my God, we're so great with this.
You want to do one more?
No, but I want to do this real quick. Okay, I'm going to take a turn that a lot of people watching and listening will probably have heard if they've ever been pregnant or had a friend that was pregnant. It just comes up so much. And okay, Marybeth, don't say anything. Okay. I'm going to say how I would explain this to a patient in one sentence. Okay. Echogenic intracardiac focus. This is echogenic, meaning bright white. Mm-hmm. Intracardiac, it's inside the heart. Focus, it's a spot. Now you go.
Bright white spot in the heart.
Bright white spot in the heart. So I say bright white spot in the heart, but I break down each word.
Yeah, but that's exactly what it is.
Just because it's a bright white spot in the heart.
Bright spot in the heart.
And then I say, I'm going to refer to that as an EIF from now on through our consult. And just so you know, that's what it means.
That's what it is.
Yep. Bright white spot that's in the heart. Mm-hmm. I show them a picture.
Yep.
There are resources to go to, but just don't go to random spots for people that have maybe, I don't know, like they're not qualified and they say things that just shouldn't be said.
There's a lot of misinformation out there. Yeah. And I think people that you should be paying attention to really state their qualifications up front.
Yeah.
It's really about whenever you take advice from somebody, especially in our very wild world web, like especially in this world and social media, Instagram, TikTok, always go back to someone's credentials.
Sure.
You know, if someone is really giving good information and you are really absorbing it and listening to it and you can't find a single credential of why they wouldn't have this knowledge, I disregard that. Absolutely. Someone who has the knowledge, who has the skills and clearly identifies who they are, what their qualifications are, what their education is. If you can easily find that, they are the people to follow.
Clear as kind.
Easily. Clear is
kind. Unclear is unkind. I also want to take a moment, as I do in most of my podcasts, and say hello to Brene Brown if you're watching.
Oh my
I'm a super fan. Are you a super fan?
I am a super fan.
I want to meet her. You know how sometimes people give you the question, like, if you could meet anyone dead or alive, who would it be?
Oh, is she your person?
Mm-hmm. Alive would be Brene Brown.
Okay.
Dead would be Maya Angelou.
Oh, good ones.
I love her.
Yeah.
I'm like, okay, now I'm all excited.
Do you want to hear, on a side note?
Yes.
So Dr. Brene Brown, she does this thing. She talks about FFTs. Do you know what FFTs are?
Yes, but my brain has forgotten. I feel like there's a fuck word in there.
Effing first times.
Yes. I listened to this on the audiobook. Yes.
And I like
she had a first draft.
Yes.
And she was like, it's an FFT.
It's an FFT. And I like to, especially students of sonography, they're like, why can't I get this? Like, and anytime you learn something new, you're not supposed to be good at it. And so I share that a lot with students and a lot of people that want to get into sonography and just don't feel like it's catching.
Yeah.
You're not supposed to be good at something the first time. And we used to say like, don't give it a name, you give it more power. She was like, you name that sucker.
You name that.
You name it because that gives you the power.
That's right.
To understand like, I'm not supposed to be good at this.
Yeah.
I'm not no one is good at anything they do the first time.
No.
So I think it's a realistic. I use that from her a lot.
I like that. And I for anyone, and clear is kind, unclear is unkind. Mm-hmm. Marybeth and I feel like are probably lifelong teachers and learners.
Yeah.
And when I worked with Marybeth closely for a period of time in my professional career.
Yeah, we've been on and off for years.
Yeah.
Professional, personal, we're all over the place.
There should be a dating show about this too, like professional people, like when we broke up, why we got back together, why we left in the first place, whatever. But I learned, and I think that I do this well, and I want to keep doing this well because it makes me learn, is when I work with ultrasonographers, I don't think there's anyone specifically in ultrasound that I haven't worked with that I didn't take something away from them, right? Like where they taught me something or I learned this. I think so many things you taught me, but I do remember there was an absent umbilical artery one time.
Yeah.
And you told me which side it was. And I'm like, Marybeth, why do I care? And you're like, well, you know that if this side versus this side, the risk of a chromosomal abnormality is higher if this one is absent versus that one.
Yes.
And I taught other people that.
It's statistically more the left.
Yeah.
But the right, especially for genital urinary abnormalities, a little bit higher chromosomal.
I taught that to people that I worked with that were in very small towns when I was doing I still do underserved area work. And some of them may or may not have been MFM trained.
Right.
And they also were like taking call at night, doing all this crazy stuff. And they didn't know some of the extra details and knowledge that you knew, that you taught me. And I just went, it was so much fun. I loved it. But I also have to go back to the FFT portion too, is that when you say, no one's good at something the first time, right?
Yeah.
I wanted to be a doctor since I was like 14.
Yeah.
And you said, you knew what you wanted to do when you were 16.
Very young.
I identified when I was in college, actually in high school, I was a very poor test taker.
Mm-hmm.
And in high school, I skipped a year.
Yeah.
I still graduated within the top 2 or 5 of my class.
Okay.
So I wasn't challenged with being able to do like book smarts.
Right.
But when you put me at the SATs and the PSATs or the...
How'd you do on your MCAT?
Oh, girl. So
I've often wanted to just take it.
Yeah. So here's what I'll tell you, is that I identified that I was not a good standardized test taker.
Right. Those are two very different things.
Very different. Mm-hmm. And my mother and father were both in education. And so I felt very lucky to have people that were like, yep, you're smart at this, but you're not good at those tests.
Right.
And so I went to Texas A&M. They were local. That's where I grew up, in that same city. Mm-hmm. And they had a test-taking center where you could go and try to find out what's wrong with your brain. Why can't I take these tests?
Well, even like tips of tricks of how a test is written.
Exactly. Mm-hmm. So I went and took days, from what I recall, of all these little like tests, cognitive tests on like, how do you do this? How do you do that? And then I went back in maybe a week later. So I found this report the other day.
Yeah.
It's fascinating to me. And it's like, you're above the 95th and 98th percentile on all these things.
Yeah.
Okay. And then they got down to reading comprehension. I was like 46th percentile.
Oh my, really?
And I was like, what? I don't know if I don't retain it, or like when I read it, like if I learn it in a different fashion.
Yes. Yeah.
If I do it.
Yeah.
If I participate.
It's almost like you need very tactile kind of things.
They actually said to me, you should do something with your hands. They literally said,
I could see that.
You'd be good at something with your hands. And I'm like, okay. So
you can feel it, mold
you can feel it, and
then you put the repetition in there.
Yes. So I think I would have been a good mechanic, or maybe like an artist or something like that.
Yeah.
But I knew I wanted to go into medicine, and then I chose my field on what I felt passionate about as I went through the medical field.
Right.
But I don't recall, I always did poorly. Like I would just get past what they needed for me to pass for USMLE or MCAT or whatever it was.
Right.
And then I failed a board exam.
Yeah.
Like I got so far and I'm like, oh my God, I'm going to do it. Because it was harder for me than for some people, because school was a lot of the first 2 years of medical school. It's just read, take a test.
Yeah.
And that continues throughout our lives.
Yeah.
And so I had issues with the board exams, because you're not only studying for those exams, you're also practicing medicine every day.
Right.
In a fashion that has nothing to do with the way the board exams are given.
Okay.
So I'm practicing with empathy, explaining, doing.
Yeah.
And I have to take 4 exams, 2 that are written, 2 that are oral exams, and do things that I do not do on a regular basis.
Yeah.
Now, is it around the topic of labor and delivery or ultrasound? The topics are the same.
Topics are, yeah.
The way to do it, I've never practiced doing that.
Yeah.
Right?
Yeah.
And it was gut-wrenching and crushing to me. Mm-hmm. And I would say for a while after that, I just didn't want to talk about it.
Yeah.
But when you bring up how Brene Brown talks about vulnerability, right? Mm-hmm. And like, I needed to name that bitch, right? I needed to put a name on it and be like, it's called failing an exam, not being a failure.
Yeah.
And I'm not a failure. But it makes you feel like you're inadequate. You're not good.
Mm-hmm. And that you'll never be good.
Right. And you're never be good
enough.
And it's like, I knew an ultrasonographer who failed the echo board. Is that echo boards, right?
Yep.
And then she took it again and did fine. Mm-hmm. She is an excellent ultrasonographer. She's excellent as a diagnostician of fetal hearts. And she has been forever.
The practicality of the exam is there.
Right.
But it's those, and in test taking, they're also like, here's 4 things. What is the most likely?
Yeah.
You're like, but they're all correct.
I hate those. I feel like it's just like, I just want to say and throw a tantrum and say it's not fair. But I teach test-taking skills now.
Yeah.
Because I took the thing that I felt, again, I interpreted it that way. It made me feel lesser of a person, lesser of a doctor. And I took it and I was like, nope, it's not going to own me.
Yeah.
Right? And so I just want to bring that up because, again, I love Brene Brown. I don't know if I've said that yet. But for people out there who are taking board exams, even I actually helped someone pass a nursing exam called an NCLEX.
Yeah.
So I reasoned the exam. That is a hard test, by the way.
Very hard test.
That is not fun or fair.
Whenever I hear about that, I'm like, like these nurses that pass that test.
That test is hard.
It's impressive.
And all different types of questions too. They're not all multiple choice.
No. They're all over the board.
And some of them, it's like choose however many are correct.
Well,
fill in the blank.
It's also like the whole spectrum of nursing.
Oh my gosh.
You're talking like pediatrics. You're talking fetal. You're talking elderly.
It's everything. It's everything.
Medication. Oh my gosh.
Yeah. So like if you haven't failed a board exam in the medical field and you're taking one, particularly for OB or maternal fetal medicine, reach out to me. You can find all my stuff. If you're doing the exam or an exam for something else, reach out. If it's a written exam or an oral exam, I have things to help you. And when I say I have things to help you, this is not me like I looked it up in a book and I think this is what works.
No, that's not
this is like I went through this and this is what worked for me. So is it going to work for everyone? No. But if you want somewhere to something to try rather, I will empower you with the most resources and ability to pass these exams. Yeah. Seriously. It is just, oh my gosh.
Some people are great test takers and they're not good practitioners.
True. It goes
both ways. It really does.
And the other thing too that I say, I see all these things. I watched something else on Netflix and it was about sports and they oftentimes talk about, so I've been watching a lot of golf lately. I started playing golf. I don't know if I told you. Yes. Okay, yeah. It's very fun and frustrating all at the same time.
Yes.
And golfers can be great. And golfers can have a bad day, right?
Yeah.
And a lot of golfers who are great now, they didn't start out great.
No.
They practiced and practiced and practiced. And you hear all these stories on anything on TV about how an athlete was bad and they lost and lost and lost and now they win. And they get accolades now and everybody's like, look how hard they worked.
Yeah.
I have yet to hear a patient go to a doctor and be like, look, they had failed a board exam and look how far they came and now they're this great doctor.
Yeah.
People are usually like, oh, I'm not going to go to a doctor that failed a board exam. First off, you're probably not going to know they ever failed one.
If they're smart, yeah.
I mean.
They've never advertised that because that's just part of the step.
No, but you probably could find that information somewhere.
Yeah.
But here's what I challenge people to do, whether you're the physician or you're the patient seeing the physician. Is your physician good at talking to you? Did they work hard to overcome maybe having had failed either an exam or having to take an exam again because they moved or getting a new license or, going above and beyond?
Yeah.
Because think about the athletes that you're like, man, they had to overcome. And how cool is it that they overcame and did all these things versus it was just easy for them?
Silver spoon, like just handed to them. Yeah.
There's a book called Grit by Angela Duckworth. And it is all about being gritty, right?
Yeah.
And I'll tell you, I'm gritty.
Yeah.
Like you tell me I can't do something, I will do it.
Yeah.
You tell me I'm not good at it.
That's the core of who you are.
I will become better.
How you were raised.
Yeah. So like, I have doctors like that, and I think they're fantastic.
Yeah.
And I'm also not going to look at, oh, did you get your degree from this university versus that one?
Yeah.
That doesn't resonate with me as what makes a good or a not good provider.
Yeah.
So
fair.
I just wanted to share that.
Fair.
Okay. All right. We're at question number 10 now.
All right.
Question number 10. What is considered a normal length of a cervix in pregnancy? And I'm going to shorten this for you at 20 weeks gestation.
Anything, we want at least 2.5 centimeters vaginally, but really over 3 centimeters is what we're looking at.
I love it. Okay. I'm going to give you.
That is a clear guideline.
Clear guideline. Clear is kind. Oh my God. Okay. 10 true false questions. Super fast. You ready?
Okay.
I'm not even going to say true or false. Just let me know your thoughts. Okay. A fetus can have hair in the womb.
True.
A fetus can hear.
True.
If a pregnant individual eats sugar, this will make a fetus, it'll wake up a fetus if they're sleepy.
Maybe true.
Okay.
I don't know exactly how true that is. I'd use it though.
Everyone should be screened for diabetes when pregnant.
Absolutely.
Everyone should be screened for thyroid disorder when pregnant.
Absolutely.
Everyone with 2 prior C-sections has to have a third.
No. But I don't think there's many doctors who offer the VBAC.
Good points.
right? Like that.
Twins.
You have to have a provider that feels comfortable to do that.
Twins that are the same gender are always considered identical.
False.
No cheese is safe to eat while pregnant.
False.
Someone trying to get pregnant should start taking folic acid before pregnancy.
Sure.
Baby aspirin is an over-the-counter medicine that can prevent a certain type of high blood pressure during pregnancy.
Oh, yeah.
I love it. Okay. Marybeth has been a fantastic guest. Thank you guys for watching today.
I feel like we covered a lot of ground there.
We did.
We really did.
Lots of tangents. Lots of tangents, and I love them all.
But I will say, for all sonographers working with maternal fetal medicine and perinatologists, train your sonographers to think like you.
I love it.
And we are such a team and such a supportive team that I think it's important to think of it like a team. You know what I mean? Just like our little teamwork here today.
I love it. I love it. Well, I hope everyone has been able to expand your knowledge today, develop some skills. And as you can see, we're working on having an impact on your life, the life you might be creating, the life of those around you. Thank you so much for watching. I'm Dr. Lexi, and as always, wishing you a happy and healthy pregnancy.